Good morning to all members, all departmental officials. Good morning, Minister Mbombo. This is Tuesday, the 15th of March, 9 o'clock, and this is the Standing Committee of Health. Please allow me to welcome all members present, as I said, Minister, all departmental officials. And I do see that we also have members of the public present here today. Can I please ask you to just move a bit closer where you would have access to a mic? So I will also need you to introduce yourself for the record, but very much welcome to you this morning. We do have online member Regan Allen. We did indicate that this is an in-person meeting this morning, but member Allen do have an emergency this morning, so permission was granted that he would be able to log in online. So at this stage, members, I believe member Bakufos will also join us online. No other apologies were received from any other political parties or members. Member Plato, I was just asked by the procedural officer if you do mind to just get a bit closer to us, please. Thank you very much. At this stage, without further ado, I will now ask members to please introduce themselves.
Good morning, everyone. My name is Rachel van Voorgang.
Good morning, all. Dan Plato. Thank you.
Thank you very much.
Good morning, everyone. I'm Member Baku Force.
Thank you, Member Bakufos, and welcome to you.
Good morning, Chairperson, and thank you so much for your indulgence this morning. Good morning to the Department and the Minister, Regan Allen.
Thank you very much, Member. Welcome to you as well. Minister?
Morning, everyone. Noma French Mbombo, Paul Calhart, Department of Health. Thanks.
Good morning, everyone. Keith Kluti, Head of Department. Thank you.
Good morning, Honourable Chair and members and MEC. Simon Kay, Chief Financial Officer.
Good morning, all. Sadiq Karim, Chief of Operations, Health Department.
Morning, Krish Vallabhji, Chief Director Strategy. Thanks.
Hi, morning. Wilna Hanekom, Deputy Director Finance.
Good morning. I'm Desra Mohani, Director Management Accounting at Health.
Good morning, Chairperson and members. The name is Anda Ngosi, Chief Director Financial Management. Thank you.
Good morning, members. Name is Akona Stemele, Community Outreach Officer in the Office of Minister Mbombo.
Good morning. My name is Noma Wetus Bugwana. I'm the spokesperson for the Health MEC, Dr. Noma French Mbombo.
Thank you so much. And I will now move to the back. If you can kindly indicate your name and also which sector. Can you please use the mic, ma'am?
I was looking for it. Good morning, everybody. I'm Halima Isaacs. I'm from Menenberg Health Committee, and I'm also serving on the Menenberg Heideveld cluster, and as well as a nominated member for the MEC office.
Thank you very much.
Good morning, everybody. My name is Joyce Malebu from Guguletu. I'm one of the Guguletu Health Forum members. Thank you very much.
Good morning, everybody. My name is Leslie Sylvester, and I'm also on the Klipfontein Sub-District Health Forum and appointed member of MEC for the cluster of Heideveld. Thank you.
Thank you very much, sir.
Good morning, members. I'm Henry Bothman, and I'm from Mitchell's Plain Health Committee, Deputy Chair, and I'm working on East Ridge clusters.
Sir, can you perhaps repeat which sector you represent, please?
East Ridge cluster, Mitchell's Plain.
Okay, sure. Thank you very much, and a warm welcome to you as well. Any apologies?
No apologies, Chair.
Thank you very much. None from my side as well, except for the members that did indicate that they'll be online, but they do are in attendance. Members, Minister, Department, and members of the public. I would at this stage ask Minister Mbombo just to give us a brief overview, if possible, in 5 minutes, in terms of us tabling the budget. And then immediately after you, if the HOD has got any inputs further to provide, he's most welcome. Thank you.
Thank you, Chair. As an intro, I'll just do the intro and then you'll still come back in terms of, okay. Thank you for the opportunity to present the 2022-2023 appropriation of this budget, which is about 29.094 billion. Looking at the medium term, it means that the other 2023-24 about 27 and 2024-25 or 27, which might drop, but because we're focusing on this one, it's a 29.094 billion. It comes at a time that whilst now we are not in a wave yet, but we are still part of the COVID, and therefore it means that the budget that we are bringing, it should take into effect what if there is a fifth wave. And also it comes at a time where we have to recover other health services and non-COVID health services. When we say recover, it doesn't mean that we will need to, we will be able actually to even to bring it all back at the same time, because many have been left behind, like the mental health, which is also due to the post-COVID impact on the whole well-being of a community. The issues of the backlog on the surgeries is part of it. And also in regard to our aging infrastructure, as you know that some of the hospitals, they are more than 100 years old, where you have to take into consideration the infrastructure. And then the other part, it's about, it comes at a time previously when we tabled the budget here, the issue of the wage bill, which at the time the unions were still negotiating, or actually the then finance minister took it to the court in regard that the state cannot be able to afford the wage bill, which was negotiated previously on 3-year period of the increase of the salaries. So this takes into consideration in terms of that we have to put aside that money, because it has to be the provinces now that have to endure that part of the money. And then lastly, Chair, it comes also at a period that not only the mental well-being of the community, but also the staff being affected in regard to COVID has also had an impact for those staff who passed on, and also those staff who were affected. So the issue of the morale and also the journey to recovery has to take into effect. And also lastly, about the staff, it's about the issue about that now that we're out of the wave, how do we deal with the issues of some of the contract staff that will have been part of the COVID during this time. And lastly, the issue of the economy. If the economy goes down, it means that all other sectors, specifically health, will absorb that part of it. When it goes up, it also actually contributes to the health. Hence, so socio-econo-cultural determinants of health are very crucial, especially in regard to the jobs, the dignity to the people, and other factors. Thank you, Chair.
Thank you very much, Minister. HOD.
Thank you very much, Chairperson. Just to reiterate what Minister Mbombo said, as an accounting officer, on behalf of the senior management team, especially our finance team, we are presenting ourselves in terms of the appropriation of 29 billion for this financial year, 22-23. As the Minister said, you need to understand the context of 22-23. It is a year that follows 2 years of significant disruption of COVID. 4 waves of disruption to the normal pattern of healthcare service delivery to what citizens require in terms of healthcare delivery in this province. So if you take 4 waves of disruption, this year is a year of having to continue to be ready to respond to whatever COVID does in terms of a 5th wave and a 6th wave, continue to vaccinate people as we return to recovery, but at the same time have to deal with 4 waves of disruption to healthcare services generally. And what that is showing up in is a rebound of healthcare needs that the healthcare system has to cope with in this year and in the years coming. So it's a rebound in sick and ill patients coming to health services now because they've not had the TB treatment for the last 2 years that they had for the 5 years preceding these 2 years. It's people that have had surgeries cancelled because of COVID that they didn't have in terms of surgical waiting lists that we've worked significantly down in the last 5 years. The 2 years have put paid to that. So we have to catch up with surgical backlogs while we have to deal with sick TB patients. And the biggest thing that's facing our system is mental health has been something that has been a pressure before COVID. It is significantly exacerbated by COVID. So we're presenting a budget to you, which has to be seen in a context of the competing things that comes at the healthcare system. So COVID is not gone. COVID is going to be around with us for at least another 2 years. Vaccination mandate is not gone. We have to vaccinate people. But we also have to recover and deal with all these backlogs. So all the money that you see is allocated to be able to look at the entire healthcare system to respond. Now, I'm saying to you proudly, we're sitting in the Western Cape healthcare system. We have generally coped in terms of what COVID has thrown at us. Our next big challenge for the next 5 to 10 years is to cope with a recovery in terms of what COVID has left behind. And therefore, I'm proud of the team here and the team away from here that will navigate us through this specific period, but it will be a period of challenges. It's not going to be easy. It's challenges. There are more needs than the resources can provide for. It therefore means that we need to make wise decisions. We need to make decisions that takes people along with us. And the big thing we require in this year is a social compact. So Minister Mbombo will be hosting on the 29th of April a summit of bringing all the players together to ask them to co-create with us, how do we navigate these difficult choices? That includes community structures, it includes people from civil society, it includes the standing committee potentially, but it includes a whole lot of stakeholders because in this province we need to take hands. We can divide if we want to, but it's not going to be productive. It's taking hands for the most vulnerable because that's the people that suffer most. It's the people that's most vulnerable that's dependent on the public sector services. Thank you, Chairperson.
Thank you very much, HOD. Members, at this stage, any questions from your side? I do not see any hands online. Member Van Vogel.
Thank you, Chairperson. Chair, mine is not a question. I will ask when we go into the annual report, but I must welcome the input from the Minister and the HOD. And I know this is really a difficult time for us, of let's say for the Department of Health. And we want to ensure the department from our side, we will assist where we can to ensure better service for our people. Thank you, Chair.
Thank you very much for that comment, Member.
Chairperson, thank you very much. From my side, it's always difficult during these COVID times and so forth, the last 2 years for government as a whole, from national to local, including provincial. And to deal with issues such as COVID and so forth. I think the department, looking at the speech of the finance minister yesterday and looking what's on the budget for health, I think health have done well during these trying times under difficult circumstances. Good bunch of officials and so on. But I also think that I want to focus on one or two issues, just for clarity's sake. The one issue is the issue with regard to the state of clinics, the state of day hospitals, the maintenance program. If we believe we will make some necessary inroads just to remedy the situation for the people out there, although I want to say I agree with the fact that that even will be a difficult one to deal with. But there's always complaints in that regard. I see what's on the budget. That is why I'm not going to refer to the contents of the budget, but just in general terms. What do you think as HOD with regard to that particular issue? Thank you.
Thank you very much, member. And just for members of the public, we will most definitely provide you with the opportunity to make other submissions or to raise a question to the minister and the department. So once a minister provided a response to member Plato, we'll then dive into the budget from pages 215 to pages 251. The annexures are on pages 252 to 287. And then after members have exhausted the for you to also make your submission and raise your questions as well, then I would then give you an opportunity. Ma'am, do I see your hand?
Yeah, good morning. I just need a copy of the budget, please.
I'm sure we can arrange one for you, Ms. Da Costa. Monday, would you be able to ask for a copy? Thank you. I'll provide one for you. Thank you so much. Minister, I'm giving over to you in relation to Member Plato, and then the HOD can fill in necessary.
Thanks, Member Platt. I think we can cover as we go on, especially on program 2. I think it will be covered. I think we can wait for that.
You are satisfied, member, that it will be covered? Thank you very much. Members, having your budget in conjunction with your annual performance plan, Member Van Vogel?
You're going to repeat yourself, Chair. Miss, you are saying we are working from page, which page?
Pages 215. Let us take 215 to 220. Is that in order? Any questions on that pages? Members, can we just also, for the sake of time, bearing in mind that we do also have other parliamentary privileges where we can raise the questions either in the House or written questions as well, so that we at the end also see fit that we make room and time for members of the public that made time to be here this morning. So from pages 215 to 220, let's limit it to 3 questions per member. Is that in order? I see you not, Member Van Vogel.
I have so many questions, but I will try to reply with your request. Yeah, I'm not sure. Are you giving me a chance to ask questions, or are you?
Yes, I'll provide you an opportunity to ask your questions now from pages 215 to 220.
Thank you, Chairperson.
Let's stick to the 3 first and see how far we get.
Okay, thanks, Chair. Chair, on page 215 under mission.
Member, can you just speak into the mic, please?
Okay. Thank you, Chair. Thank you, Chair. Chair, on page 215, title, heading as mission. Point of reference, we undertake to provide equitable access to quality health service in partnership with the relevant stakeholders within balanced and well-managed health system to the people of the Western Cape and beyond. Now, my question on that issue on that point is how does this applied in health facilities in poor working communities, such as Khayelitsha District Hospital? And how has this budget response to the plea by the hospital management and board for the additional 115 million? And has this budget made provision for this additional 150 million? And if not, why not? And how much additional budget is the hospital getting this year? Chair, then the second one, it's page 216. Heading is demands and changes in services. I want to know what is the provincial government strategy to address increased services. I think the HOD touched on the issue of the backlog in all the other type of services, because your focus was for the past 2 years on COVID-19 and this, the different waves that we experience. So what I want to know is how are we going to address and increase service pressure across all healthcare facilities, and how does this budget respond to it? Can we get an overview of backlog on surgeries and all the other services mentioned in that sentence? Then the last one, Chair, is 217, and then the budget decision as the point of reference, the National Health Insurance. Can you provide more or explanation regarding the NHI grant? What are the conditions attached to it and how it will improve services at our hospitals? And second, given the DA stance on NHI, what measures are in place to ensure full expenditure of this grant? Thank you, Chairperson.
Thank you very much, Member Van Vogel. Your questions are 3, but it's quite packed. So I must actually say that you've now exhausted your 5 pages. But nevertheless, Member Plato?
Not at this stage.
Not at this stage. Member Bakofos?
Thank you very much. Thank you very much, Chairperson. My question will be on page 218. The heading is own revenue. I would like to know how much of own revenue was collected during the current financial year, and how much of this is reinvested into the department, and how much is sent back to the provincial treasurer. Can we get a breakdown of revenue collection on each year since 2014 to 2021-2022, and how much of this was sent back to the provincial revenue? This is my first question. And my second question, Chairperson, is on 218 again, in COVID-19 and vaccines. I would like to know what exactly will the funding for vaccination program be spent on? Is it the same funding to procure vaccine which failed to materialize during this financial year? If so, what is the purpose of repeating this exercise? And Chairperson, as you indicated, this one is my last question. Still in 218, the heading is population growth. Chairperson, I would like to ask from the department, how is the budget population growth? Can the department provide population growth for Khayelitsha between 2012 and 2022? This is my last question, Chairperson. Still in 218 on the budgetary process and construction of the budget allocation. Chairperson, I would like to know what are the reasons for the reduction of the core budget and of the COE budget, and what is the estimated number of staff that will be affected, and what will be the impact on service delivery? I thank you, my Chairperson.
Thank you very much, Member Baku Force. I do not see any further hands online. You did not. Member Baku Force?
I lead.
The last question.
Okay, my last question.
Yes, can you please repeat your last question?
Okay. My last question, I wanted to know what are the reasons for the reduction of COE budget? What is the estimated number of staff that will be affected, and what will be the impact on service delivery? That's my last question, Chairperson.
Is that in order, HOD? You got. Okay.
On page 218.
Thank you very much, member.
Thank you.
Yes. Can I perhaps just add, Member Binfoko made mention of the energy. Is that, what is it, 18 million? Is that grant divided into phases, and what exactly will the impact of that grant be in the Western Cape itself? And then member also made mention, I was going to keep this question for later. Yeah, let me keep this question for later. All right. Yes. Minister, I'll give over to you and then to the HUD, and then you can might fall in. You might proceed, Minister.
Taking consideration of the time, I'm not going to respond to specific questions. HOD and the team, they could be able to do so, but it's just for a policy imperative generally in regard to the budgeting, and that will cover some of these questions. But generally, how we get the money is through the National Treasury for the health sector. They use a population, which is actually in education, they do the population in terms of what is the current population, in as much as that the last census was in 2011, but they have got all of these sources coming from the Stats SA in terms of the population. Secondly, that population, we have to also divide whether it's insured versus insured, which is those that use private hospitals and also that use public hospitals, but take into consideration that the majority of the Western Cape people in farming communities, even if they might have access to the private, they'll still use public because you don't get some of the private. Making an example, when we're in Matsikama, there's no private hospital. When we're in Beaufort West and all of those. So that's the second part of it. And then third part of it is about the risk factors in regard to the disease exposures, like in terms of the TB and HIV/AIDS. But going forward, the new methodology now will be focusing also on the equity in regard to that. So when now this budget now is about where you are using that part of it, what I've just indicated. So when now the question is about what is the budget for the poor communities, what's the budget for like specific hospitals, that we consider the issue of the insured versus uninsured, and also risk factors, those communities. So it does give into effect, plus also, of course, the traffic that goes to that area. In regard to generally to the NHI, the member Von Vogel mentioned about DA. Here we are here as government. We won't be able to answer on behalf of the DA chair. We can answer only as the government. So what we presented to even to the national government health and also to the national parliament part of the hearings, where we are saying that NHI is an insurance which forms part of the universal health coverage. That's what we said. We said it's just part of the bigger thing, which is the universal health coverage. That's what we said as part of the NHI. I think let me now give opportunity for the department to respond to specifics. Thanks.
Thank you very much, Chairperson. So I'll go very quickly through the questions. Member Van Vogel's first question on page 215. In terms of a balanced and a well-managed healthcare system, and a specific question, what does it mean for Khayelitsha Hospital? And a reported need for an additional 150 million in Khayelitsha Hospital. So let me put it to you very clearly. Our allocation is in terms of equity. We look at how many people live in an area, how many people drain to a hospital. We provide equitable allocation for Khayelitsha Hospital and equivalent hospitals like Karl Bremer, like Mitchells Plain Hospital, like Victoria Hospital. And that is the benchmark we set. We've set that benchmark for many years. So what you currently get as a Khayelitsha Hospital allocation, it is equitable, comparable to what has been given to Karl Bremer Hospital, Mitchells Plain Hospital, and Victoria Hospital. In terms of the specific factors at Khayelitsha Hospital, you have to see what is the disease profile of people that are living in a drainage area of any hospital, and what do they present with. Now, Khayelitsha has got a history that the social determinants, it's not the population factor, it's social determinants, that there are higher percentages of trauma and violence compared to the drainage area of other hospitals. So it is more important for us to understand the social drivers of why people present themselves to a hospital if the hospital got equitable budget allocation compared to other hospitals for the people living in the drainage area. So that is why the recovery strategy of the Western Cape government, which is about addressing violence and safety, is a very important issue. So I'm the co-chair on the safety recovery, and we are doing the analysis, and we're presenting tomorrow actually to Minister and the other ministers in cabinet what the dashboard of safety tells us in terms of why people in Khayelitsha Hospital on a weekend and at month-end weekend have more people in the trauma unit compared to other areas. So it's really about understanding what it is we need to do about the drivers of trauma and violence in that community. The same you would go with why do people get TB and HIV, and why would they present to the healthcare system, which means you need to go back and say, why are we not picking up the TB and HIV through the primary care system, which really then needs to strengthen the system in that regard. And the same I can go for chronic diseases of lifestyle. So the short answer is the department is not allocating 150 million more in Khayelitsha Hospital. The department is taking the pressures at Khayelitsha Hospital seriously and looking how an entire system should respond to mitigate the pressures as related to Khayelitsha. If I go to the next question, which is then Member Van Vogel's second question on page 216, the issue about demands and service practice. So Member Van Vogel, this is the key question that our entire department have to face for the next 5 to 10 years, the whole healthcare system in the country, and it's a global phenomenon. You have to say, with what you have, which is a demand for services, and what you have as resources, how do you balance that wisely over the next 5 to 10 years to meet the backlogs that's been created? So the first thing that you're asking is, what is the backlog? So we have a backlog for elective surgery at all our bigger hospitals. We have a backlog for knee surgery. We have backlog. So elective is somebody is not about to die of surgery. They can wait, and that is being delayed. So we have long waiting lists for that. And when we come to the Mandela Day in July, there is a backlog. We're working with a whole range of stakeholders to help us with surgical backlogs. So we're also saying we have resources, but we are working with our social partners from outside to help us with this backlog. And it's a plan for the next 2 to 3 years of how to systematically work on that backlog. That's one example, because we can count how many people need surgeries. The problem is, it's not just the people that need elective surgery. The reason why they can't get into that is there's a lot of people that needs emergency surgery. Now, emergency surgery comes from, there's a lot of accidents. There's a lot of people being stabbed. So those same things that I just spoke to you about, Kailicha, are the reasons why people can't have the elective surgery, because there's too much trauma and violence around, firstly, and it makes emergency service. Also, if somebody became ill from something like cancer, and now they are becoming ill, they need emergency or urgent surgery, that also pushes that up. So that's just an example of just on surgery, how we have to deal with it. We said to you, that's not even probably, it is pressing, but it is only one component of service pressures. If I explain to you how TB works, now if you don't pick up enough TB cases, you will have people that then in 6 months' time or 4 months' time that have TB that's not been picked up. They start getting sick, they lose weight, they cough a lot, they sweat at night. And then before you know it, they land up in the emergency center, very ill, having not been picked up with TB. And then they are in the hospital, in the same emergency center where somebody comes with a trauma. Then we have to go and have a waiting list now, all of a sudden, for TB hospitals, to get ill people into TB hospitals. That is the impact of 4 waves of not testing enough people to pick up TB early enough. That's TB. Again, that is quite a big burden in the Western Cape that we have to deal with. But the third burden is probably the one that keeps us awake more at night, more than the surgery, more than the TB. And that third burden is mental health burden. That is, then mental health is driven, we also know it, again, social determinants. So the reason why people come to ECs with mental health is they come because their behavior becomes a problem. So somebody that is taking substances, young people, and the substance abuse comes to a point where they have an acute episode. The families are completely terrified. The mothers, the fathers, they're terrified of these young people that are taking tuk, and then they cause chaos in their families. That is the big driver of why our emergency center is full of people with mental health conditions, which is driven by substance abuse. Again, a social determinant, and understanding why you use all of those. So remember, Windvogel, I'm giving you that because that is the work of our healthcare system for the next 4 to 5 years, is weighing up the surgery with the TB, with the mental health, and not even to mention things such as women's health conditions, such as picking up for cervical cancer, children's conditions, to give children immunizations that they don't come with measles to hospital. Those are all the things that we have to weigh up. And we're not saying it's going to be easy, but we're saying we have to consider all of that. And when we say we have resources and responses, we need to be very intentional about how we weigh all of those things up. In terms of, but for that, Dr. Karim and his team is developing what we call a recovery plan. So we have a recovery plan for that. The one big pressure that Minister Mbombo always asks us about, when I say all of that, and already I've forgotten it now in this, is the pressure on maternity and neonatal services. So that is pregnant women that must deliver, and what we do in our services when that is pressurized, because we put the mother and the baby at risk if we don't have sufficient birthing and delivery services. That has not slowed down in COVID. So we add all of that together. We have a recovery strategy for all of that for the next 3 years. But as I said earlier, it's not as if COVID is going to go away. COVID is still going to be with us. So we have to deal with COVID while we do this at the same time. If I go to page 217, there were 2 questions on NHI. So remember Windvogel? The issue is, our answer is actually very clear. NHI grant is like any other conditional grant we get. The conditional grant has got conditions to it. We have a team of people, we look at the conditions, we take the allocation, and we spend it. All the NHI money we've had for the last 4 years has been for contracting sessional GPs in rural services to work in our services. We spend that grant every year, no problem, because the conditions are clear. We use it as our service. If we weren't going to use it, we won't accept the money. But for us, it is serving, it's got a specific condition for that. What the National Department has done this year, they've consolidated some other grant lines under the NHI. So you now see all of a sudden a mental health service component under NHI. That is to relieve pressures on the mental health platform. But there's an additional grant on this. And that is probably for the first time to test out some models of how to work with public and private in geographic areas. And that is what is called an indirect grant. So that money will remain at the National Department, but we will be working with the National Department to actually spend that money in our services. So from our perspective as officials, we spend the money like any other conditional grant. What you have in HIV, what you have in infrastructure, what you have in National Tertiary Service grant, it's exactly the same for us. Whatever the condition, whatever the money is for, it gets spent and we work with our National Department in relation to that. So that answers your question, Member Chairperson, because the issue is you must understand that the money that's currently set or has set under NHI grant had nothing to do with implementing the NHI bill. It's got nothing to do with it. It's a funding line for specific things. The NHI bill is something that's been listened to in National Parliament. It needs to go through a process. That's not been adopted as an act. As I'm saying to you, the money that we've used over the last couple of years was about additional sessional doctors to work in rural areas. Now we're going to use some money for mental health services. The one that's going to be indirect grant, that's the one held by National, is for the first time to start testing some of the ideas that lives in the NHI bill. That is not going to show in our books. We will be working with National because the Nationals approach us. We're the one province that can test some of those concepts. It's going to be very difficult to test some of those concepts in other provinces that has more challenges than us. I hope that clarifies the NHI. Then on page 218, Member Baku Force's questions. So the first question she asked on the own revenue, I'm just going to ask Mr. K just to report where we will look in the future in these pages that's coming, where there's going to be lines on own revenue. There will be some reference further on. But the big principle, Mr. K will explain to Member Baku Force, is we have a specific agreement with the Treasury, Provincial Treasury, that if there's own revenue and money that we bring into our system, by and large, that money gets given back to the department to use. So, but you will give the more technical answer on that. The second issue that she asked is about vaccines and what will the money in vaccines be spent for? Now, just be clear, in vaccines, the money we spend on here in this province, we're not buying vaccines. The vaccines get purchased from the National Department of Health. So what we spend on vaccines here is on the ability to offer vaccination. That's the cold chain, to keep the vaccines when they arrive, to get it to different sites, and mainly spend on staffing, nursing staff to be able to be vaccinators at the sites. That's mainly what we spend on. But there are other items, and that's to administer, to buy fridges, to make sure there's cold chain, all of those other things, which is to administer the vaccine in that regard. Then a third question to Member Baku Force about population growth. There is very clear population growth that gets used. It's mid-year estimates. We can give them the estimates. I can tell you that the growth in Khayelitsha compared to the others is not significantly higher than compared to other areas, but we can give a breakdown of that population growth because we use that on a year-to-year basis. And then the last question, Member Baku Force talks about compensation of employees. The sentence reads that what we got for compensation of employees in terms of the agreement, the labor agreement around compensation of employees, we got the money for 22-23, which is this year's budget. So it is in our budget. What you are seeing here is that for 2023-24 and 2024-25, that money has not been included in the preliminary allocations for those years. But as Mr. K will tell you, we're currently in this country working very much on a one-year budget. So this is only preliminary figures for 23-24, which doesn't show that allocation. It's been included for the first year. It's not been included for the subsequent years. Hopefully, Chairperson, I've answered all the questions. Mr. K?
I believe so. Thank you very much, Mr. K.
Thank you, Chair, and thank you for the questions. So the breakdown on revenue is 222. At the bottom, it shows departmental receipts. But as Dr. Kluti has said, revenue is included as part of our budget, so we need to collect up to, in the next year, to be 396 million rand. Anything above and beyond that does get surrendered to the provincial treasury, but it generally comes back to us in the adjustment budget. And that was one of the reasons why we were able to fund our additional COVID pressures for the last quarter, because the provincial treasury allows us to take our revenue over collection as well as our savings in our normal vote. So we were then able to use that money to mitigate against certain pressures in this current year because of COVID. And then the last one, Dr. Kluti is 100% correct. It's no trade secret. We are doing one-year budgeting in this country. We've been doing it for a while, so it becomes very difficult to do comparators. But if you turn to page 250, it gives an indication of the total number of people that we would have to cut in order to balance the books. So this is done on a balancing of the books. So you'll see that in 23-24, we'll drop from 36,170 people to 33,915 in order to balance back to what this is. So obviously there is significant lobbying, not just within the health department, but across all of government to make sure that we actually get our compensation increases from the National Treasury based on the wage agreements that are agreed upon, which are out of our control because they're collective bargaining agreements. Thank you, HOD. Thank you, Chair.
Thank you very much, Mr. K. Members? Member Van Vogel?
Thank you, Chair. Chair, I have a follow-up on the KDH issue. Can the HOD perhaps, he mentioned that you will use your previous systems, of processes, you will use it again this year, this book year, with the understanding, the pressure that Khayelitsha have. And I want to understand, because this Khayelitsha hospital it's close to my heart, because you saw the pictures in the newspapers. We went and visited there. Patients sleep on the floor, and it's unacceptable. So what I want to know from the HOD, can you perhaps tell us the exact additional amount that his department is going to give KDH to address the challenges at the hospital, as well as to respond to the many unfunded mandates and additional patients redirected from Fuleni and surrounding areas? And how is this budget responding to the document that the hospital management submitted to the provincial government for the additional funding? Thank you, Chair.
Thank you, Member.
Thanks, Member Van Vogel, through you, Chair. I can understand when some of these challenges that are there, you'll want to prioritize. It's like when you're a mother, we have got maybe 5 kids, and then we have got this particular one, black sheep of the family in regard to being a problem child, where you'll say, I want to save this one, forget the 99, the lost sheep. So I can understand that, but it's not only is the Khayelitsha. Whilst we understand the challenges that are there, as Dr. Casey has indicated, that there is a high level of social determinants. There's a high level of poverty, as according to the evidence, without even talking about health. Because remember, we become the microcosm where everything that is happening in the community being manifested there within the health space. So the violence that is happening there, just recently now, it was 2 days ago, 5 people were killed. Those 5 people, they become a unnatural death. So it's an addition to our mortuary, because it means now they have to be have an autopsy. The issue of the unemployment, it means that even no private health will want to go there, because in terms of the paying for the health services. So it's the number of people in terms of the quantity, which actually does have an impact on other sectors. Because the issue of the housing, that's why we have got, even every day, we've got newer informal settlements that are there, they are expanding. So it does have a huge impact on the housing list as well. The issue of schools, especially for the enrollment at the beginning of the year, it's when now people, learners have to be taken out of the culture and go to the other schools as well, which is we saw the issue about the transport and all of those that's got an impact. Similar, first of every month, you see the SASA queues in the Kailicha sightseeing mall everywhere. That is the longest that is happening. And also with the COVID, we saw how it hit Kailicha more the first wave than anywhere else because of these socio determinants that we're talking about. So the point that I'm trying to make is about, it's not only about health that is affected, it's affected throughout because it's an impoverished community. But as HOD has indicated that when you look in terms of the vulnerability index, when we do the budgeting, because there are times where we say that you're giving more money, they're prioritizing the affluent areas. We don't have hospitals in the Bishop's Court and all of those. They are almost in the poor communities. And if you look in terms of the beds, numbers, because he was comparing Kailicha, which is more or less has got a similar number of beds like Kalbrima, and also doing, offering the same comprehensive packages like the Victoria Hospital, as well, the Mitchell's Plain Hospital. So it means that it's still same level. If it's a level of a high school, it is a high school, but the only difference in Kailicha, you'll add, let's say, extramural studies for computer and whatever, if I make an example of the school. Just making an example, when the pressure started in terms of matching, in terms of the packages, in terms of the response, we came up with a Kailicha Improvement Health Plan, which included that because we are unable to expand with the beds, but we can be able to do something. So we started where we say that the step down, where now for those patients who are not ready to go home, but they are ready to be out of the hospital beds. So we ended up buying beds in an NGO. I'm not sure it was a slate or whatever, I can't remember. Yes, additional beds for those. Two, the long waiting period, it was also about other things. The issue of the people waiting for their results, especially for the blood and the specimens, when now is where it has to be, not to be like taking it elsewhere, we try to expedite that so that there is a less waiting period. The scans, where we ended up buying the scan there, in order for the people not to be referred, go to the scan to take it back and then come back. We brought it there. The whole issue there by the EC, what do you call that room, with the couches where people are waiting, with all of those, because it used to be Diermekar. And also remember, there's also 72-hour observation for those who show signs of mental illnesses. So in terms of the law, they have to be observed in that space without taking them to the mental hospital. What we did, we made sure now that at least for those patients now, they need to create a psychiatry ward because there was no, unlike in the, actually part of the packages for a district hospital, generally, you don't get a psychiatry ward, but they still have to manage as part of that. Now, in all other districts, most of the district hospitals were adding these psychiatry units, fewer beds, because it takes longer for some of them to be observed, and also you don't get space for the referral to those. So in Kailicha, we ended up expanding the bed upstairs, which is now, when we're asking that, what is extra new that is upcoming, now at least they'll be adding more of the beds for that ward where they've created for such, because those patients were not even supposed to be there, by the way. And then the other issue about when people ended up taking photos, because whilst people are busy there, there's empty. It's only the security. There's no one during that space. We ended up having a night person, matron, who could be able to come and have a look, especially when they are waiting in those couches. Others are waiting for the drips, waiting for over. But most instances, some of the people is about that. I'm tired to be sitting here on the chair. Therefore, I want to take a blanket and lie down. But I think going forward, first thing, when you go to Khayelitsha, when you go to the EC, there are boxes there. There's a yellow, there's a red, I cannot recall. It will tell you that how many patients who are still waiting to be seen, how many have been seen. And in most instances, you'll find that almost all the patients in the space of the folder where still to be seen, most of the time you'll find them, they are empty. They are there where they've been seen, they are waiting for, going to be referred to the beds, to the ward, others going to maybe referred to another hospital like the Tygerberg, and then the others will be waiting for XYZ. That most of the time that's happening. So we have done the improvement plan. I can't remember what cost us then, but there was a whole lot of the cost, which is we did it even for the Helderberg Hospital where we did the changes. We did it, we are busy now for Ceres Hospital, part of the improvement plan, because we understand that you have to keep on making some of these changes as challenges happening. So what we are saying is about, it's not only a health problem, it's a social issues that ended up being absorbed by health. If a tap could be closed in regard to the so many cases, especially of the young people who come presenting with a mental problem as a result of the substance abuse, because they are more than 100% bed occupants, you'll find that is psychiatry. With the issue of the Mfuleni, actually, there isn't much of the traffic. Because it has also been my priority that coming from the people of the Mfuleni, because some of them actually from the Mfuleni, they still go to Eerste Rivier as part of it. So it's not necessary that all of them, they are going to that side of the Khayelitsha. But the point, lastly, is about now going forward, is about how do we ensure the feeder system, which is the primary healthcare in Khayelitsha. The 24 hours that's there for emergency is the Site B. It's a Michael M. It's a Site B and Michael M, for example, the 24-hour, which includes the maternity. And then all other clinics have about 7 of them. Most of them, they're under the city, 7 or so. 7 of them, they close after 4. Meaning, and also some of them there, except for Town 2, Methigoni, I can't remember. Some of them, they don't offer the whole package for the adults. How do we ensure that at least we expand those smaller Nyana's packages, I will say them, they are lower primary school level, so that we don't having a lot of traffic that goes to the Khayelitsha, especially for the green patients. So that some of the others could be seen there, because what happens is that they'll wait until it's 4 o'clock, and then afterwards they'll go to the Khayelitsha, they become green. These are the most ones who ended up feeling that I've waited so long, because they will be told that actually the average waiting is going to be 8 hours because you are green. So either get you to this ambulance because it's going that direction anyway, so that you can be seen in that clinic. No, I'm going to wait. That's why that we've been waiting. During that time, there are many red patients that are coming in. They are coming. So how do we ensure to look at not for the Khayelitsha Hospital, for the whole of Khayelitsha as a substructure, so that we can see that, okay, Site B, you are fine there because you have a 24-hour. Michael M, you are fine there, but it's mostly maternity. What about that side of Eindhoven, which is where actually these 5 people were killed? Is there anything for that is 24-hour, or is there anything where probably we must increase more of the emergency and all of those? But going forward, the Bella Hospital, that is still under the part of the planning that we're busy with, which is a Tygerberg Regional Hospital. It will, once it gets built, it will reduce the Metro East to help not only for the Khayelitsha, but the Kleinvlei, because remember there's no 24-hour in that side of the Oostenburg, the older Oostenburg side, and also part of the Makaza and all of those. So that's where we are getting at. But the point, lastly, is about, it's not only Khayelitsha. Go to Westphalia, they sing the same song, and the CEO there will say that, can I have extra 20 million? go to, I was in Beaufort West. They were singing the same song. They say that, oh, the patients that are coming from the Maritzburg or Melsport and all of those, especially now that blah, 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 can we get more money? And I was in serious where they were saying that now that the private hospital is closed and the blah, 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 in addition to whatever, can we get more? You'll see them, some of them picketing about it. So every pressures are there because there's an increase in the population in the Western Cape, and the increase in population also has got a translate to the people looking for work or for schools who are not necessarily private patients, which is they all come to us. And also the private patients, because of the cost of the medical aid, some of them also come to us. So that is the summary in terms of going forward.
Just to add to that, the Minister's explained very clearly what our position is in relation to Khayelitsha Hospital. Just in addition to that, as I indicated, the Khayelitsha Hospital allocation, it is comparable per person utilizing the hospital with other like hospitals. So it is exact. We give Khayelitsha for the workload and for the people draining to the hospital the same equitable allocation that has been given to Karl Bremer, to Mitchells Plain and the other hospitals. What we have done for the last 3 to 4 years is allowed Khayelitsha Hospital every year to overspend by 40 to 50 million. So we have actually allowed Khayelitsha Hospital to spend 40 to 50 million rand per year more than the other hospitals. And that is through collective saving that we get in other places. So you just need to put all of that together and then say that the solution that we need for Khayelitsha, we all share Member Windvogel's concerns. We all share the concerns. It is we must have the wisest possible solution. And the solution is, Dr. Vallabhji, on the other side there, when we were at these same pressures in Geef Jooste Hospital 10, 15 years ago, I remember very clearly when we went into Geef Jooste Hospital. You need to understand how many people come into the hospital. You need to understand how many people are inside the hospital that you need to process. And you need to understand how many people must leave the hospital. So a hospital is not an island. It is determined by what should come in and what you should prevent from coming in. And secondly, with what you have is your holding capacity. And if people have to leave, you need to accelerate that they need to move on to other places because you don't have the appropriate capacity to deal with all of that. That is how Khayelitsha Hospital needs to be viewed. It's part of an entire, what we call care continuum, and it requires interventions in every part of that continuum to relieve the pressure on Khayelitsha. And actually, if you ask the people in Khayelitsha Hospital, they probably need investment in other places to take the pressure of Khayelitsha Hospital, rather than to add additional resources into Khayelitsha Hospital. So that's the principle upon which we operate. Thank you.
Thank you very much. Jody, just for the record, I've seen we do have another guest joining us. Ma'am, do you mind please introducing yourself for the record as well as which sector you represent?
Good morning, Damaris Kiewitz from Cape Metro Health Forum.
Thank you very much and welcome to the meeting. Members, we're now going to proceed. We are not doing too well for time since we are having a break at 10:30 to 11. So members, we now move on to pages 221 to 230. Members have any questions on that?
Chairperson, I'm not sure if you see my hands. My hands has been up for a long time.
I recognize you, member.
Thank you very much, Chairperson. Chairperson, I hear the response from the HOD, including the MEC of Department of Health, but mine, I wanted to ask the follow-up question from the HOD, from his explanation. Given the explanation by the HOD regarding the impact of SARS,
Pakufos?
Yes, my leader.
My sincere apologies for interrupting you now. As indicated, we are not doing too well for time. So I'm going to rule now, member, that we keep our follow-up questions to either submit to the minister and department, either oral or written, because we will simply not have the time to address those follow-up questions. So at
No.
least with your initial question, you had an indication of what the department responded to it, so you can base your follow-up question.
No problem. No
response.
problem, Chairperson.
Thank you very much, member, for understanding. Members, we are now on pages 221 to 230. Any questions?
Oh, my hand is up.
Is that for pages 221 to 230?
Yes. Yes, Chairperson.
Thank you. Please limit to 2 questions now, member.
No problem, Chairperson. My first question is based on 220.
You're taking us back, member. We are now on 221 to 230.
Sorry, man, I want to say 221. Sorry, Chairperson. My first question is on page on the receipt and financial is 222. Page 222.
We've got you, member. Please proceed.
What my question is as follows: what has caused the decrease in funding allocation from the Provincial Revenue Fund? Can you hear me, Chairperson?
Yes, we've heard that question, member. Your second question, please.
Why is the provincial government not allocating funds from the revenue fund to address the other health priorities like service in rural communities and the KDF matter? That's my first question. And my second question is still on page 222, which is 222. Still on the receipt and financial and financing. We welcome the 8.10% increase in equitable share and really thank the national government for it. However, I would like to get a breakdown of which priority areas will be mainly funded with the increase. And my last question, Chairperson, is still in 224 on the summary of payments and estimates. I would like to ask the HOD or the department, what are the reasons for the budget cuts under Program 1? I would like to know that. And the last question is 225 in table 8.2 in the maintenance and repair. What are the reasons of the decreased funding for maintenance and repair as well as for non-infrastructure, and which project will be affected? Thank you very much, my Chairperson.
Thank you very much, Member Baku Vos. Member Van Vogel.
Chair, I'm going to try to be short, but
Can you please just speak up a bit, member?
I really have a problem with this times because it's not every day that we have the privilege to have the minister and a team here. And we do have these questions. You are saying we must make use of our other privileges, but it's not that easy. And I'm going to ask you to allow me to ask this question because it's a burning issue. I like to compliment people when they do good, but I will attack them if they are not serving our people.
Yes, member. Can I just comment on the time issue? We as the committee has been afforded a time limit, if I can put it like that, or a time frame as to in which we need to conclude this meeting. And also that this is also a public hearing, so we also do have members of the public that will otherwise not have the opportunity to engage the minister or the department. So what I'm saying is that members be cognizant of the fact that they at least do have other privileges, which the members of the public do not have. So if we can condense and summarize our questions to make sure that we also afford them an opportunity. So there's no way that I want to limit you just for the sake of, but we also just need to bear in mind that we have members of the public that came up this morning as well.
Noted,
Member?
Chairperson. But yeah, I want them to ask questions as much as we do. Chair, that's why I'm saying it's so difficult, but nevertheless, let me continue to ask the questions that I think it's important. I just want to mention to the Minister, bring it under attention. When we visited the hospital, there was patients sleeping on the floor. It's not that there's no patients, and we were informed by the management of KDH that that's a problem. They don't have enough beds sometimes, or let's say most of the time, as you explained, certain periods. So it's not that they were waiting to be allocated a bed. There's sometimes no beds for patients. Then, Chairperson, on the issue of service delivery, I just want to know what caused the fragmentation of the primary healthcare platform in the metro, and how is it addressed, and how will it be planned closures of clinics around the Cape Metro, impact on the constitutional obligation of the right to health for the people from affected communities. Then, Chairperson, on page 225, the new infrastructure assets. With regards to the increased budget for new infrastructure assets, can we get a detailed explanation on the rebuilding process of the GF Joost Hospital, including the how much is the total cost for the hospital, how much will it be spent on the rebuilding during the new financial year, when will the actual building commence, and then will the hospital be when will the hospital be completed, and what work has been done at the hospital, and what tasks will be undertaken this year. I think I will park there because I want the public to ask questions.
Thank you, Member Van Vogel. Member Plaat.
I will be fairly short, Chairperson, just emanating from my previous, wasn't really a question, but a remark and that sort of thing. The issue with regard to aging infrastructure, with regard to maintenance, just in short, I understand the ramifications, the issues thereof. I think on page 219, you call it significant risk. How are you dealing with that major significant risk? Thank you, Chair.
Thank you very much, Member Plato. I don't see any hands. Is that a old hand, Member Bakufos? It seems like it is. Thank you very much.
Is a new hand, leader.
Is that a new question, Member?
Yes, leader. And comment. I wanted to say no. I agree with Comrade Member Van Vogel, but as you already mentioned, we want to accommodate even our guests, the members of the community. But I would like to know that as the meeting is scheduled from 9 to 1, if they are done, we would like the department to take our follow-up questions, because we really need to address the matters that is arising in our community. We are not here to warm the chairs. We are here to address the community matters that is being accelerated to us. Thank you very much, Chairperson.
Thank you very much for that.
I wanted to address that, and I want to ask the last question, Chairperson.
Thank you very much, Member Bakufos. We have now exhausted that round with you having posed another question. I'm not going to repeat myself in terms of time. That was the slot that was allocated to the department. And yes, Member, we take our oversight mandate very, very seriously. And hence saying that members do have other privilege that they can exhaust based on asking these questions to the department. But for today, I've made a ruling that these follow-up questions will unfortunately not take us into the time allocation as provided. So at this stage, I just understand HOD, as we engage as an oversight committee to these various facilities. And sometimes you see a lot is going right. And as rightfully mentioned this morning, you see that some facilities there is room. And what I also always pride this committee on is that we can disagree, but we can also agree on a lot of things when it comes to our health response within the Western Cape. So my question would just be, and this is now in layman's terms, what does the department see as a priority, as you say, year after year? What would you regard as, say, for instance, the most needed services at a specific facility? And being in the sector and in the well-being sector, I don't believe that this department in any case does not have the best interest of the people of the Western Cape at heart. But how do you say, for instance, that one facility becomes not sufficient anymore? But you also indicated of the various influences, if I can put it like that, that contributes to that facility not being sufficient anymore. What is your role as the health department in reaching out to that other social sectors, safety sectors, to make sure that you relieve the burden from that specific facility? And how exactly do you prioritize those facilities? I just want to quickly, when I think about now in terms of relieving the pressures, in terms of maintenance, how would the department prioritize certain facilities that you see as a priority within that financial year that might not, from us as going there, might not be seen as a facility that should prioritize within that financial year? If you can just give me a bit of a background and insight into how that decisions are taken as a department. Minister?
Sorry, Chair. I also had my hand up. I'm not sure if you noted me.
You're present, member.
Yes, I'm here, Chair, but it's just that I struggled with connectivity.
I have not noticed you earlier on, member, but please introduce yourself for the record.
Okay, it's Melika Aklego, member Melika Aklego. Thanks, Chair. Can I go ahead with my question?
No, member. You just need to hang on a bit. I'm going to provide an opportunity for the minister and the department to respond, and then I will give you an opportunity on pages 1 to 230 to pose your question.
All right, thanks.
Again, I'm going to respond generally, and the HOD and the team can respond specific. Generally, in the Western Cape, of course, in other provinces as well, the quadruple burden of disease, it's maternal and child health, it's mental health issues, it's interpersonal violence, it's a TB, HIV, AIDS, and TB, HIV, and AIDS. It's chronic diseases like diabetes. These are all 5, which is the quadruple burden of disease. And in I think it was 2019, where we came up even with a rapid assessment in regard to the document that we produce, where we zoom per each and every area in regard to, specifically now in the metro, where we could be able to say in the southern and western, you might have more cardiovascular disease. In the Khayelitsha, where there are young people, you have got HIV, AIDS, and TB. In Overstrand, you get more of diseases like cancer. Like now, because I'm just coming from Overberg, where we'll find that there's an increase in HIV and TB as well. And I think now in Beaufort, where you have the high level of TB and also respiratory infections. So it is there. It means that when the National Treasury allocates money, the risk factor is around those kind of the areas. And also, if you look in terms of our indicators in our annual book, you'll get all of those in terms of not only are getting the grants, for example, related to HIV and TB, but also in regard to what is expected of us quarterly. So you have got that as part of it. Now, as people grow in numbers and also grow in regard to in terms of the life up, in terms of their lives in regard to the ages, each and every aspect gets of their life get affected. So now the question is about what does the department prioritize? Firstly, we have to prioritize in regard to that money that you are being provided. It's part of what you are supposed to do, whether there is high level or not. Now, the question which Dr. Casey responded to earlier is about the area like Khayelitsha, you do have HIV, AIDS, and TB because there are more young people. The area like Khayelitsha, it has got high number of the people, meaning the 350 beds hospital is not enough. But this is a district hospital. So you'll never be able to add another because we have already done all the pieces and have added, as I mentioned earlier in regard to that. Because a district hospital, the high level of violence that is happening there, because people come there after they've been not shot at, but at least we have got a system, information system, hospital emergency and trauma system that we could be able to see in terms of that, what are the common factors in regard to that violence. Gunshots, like if you go to Helderberg, we find that using blunt instrument. When you go to the Delft, is about also gunshots and all of those. We know all of those. So violence is happening outside. The issue of the mental well-being, as I mentioned earlier, which is we've got young people who also do the youth-related things of the being exposed to some of these risk factors like substance abuse. It does have an impact. So whether how much money we can put it there, if these kind of what I'm mentioning now are not sorted outside the health system, because I said what we see now as a health problem, it's a socio-economic problem. The more people access the jobs, the more with the girls and talk about maternal and child health, the more people at least could be able to finish up to their matric. We do know that keeping girls in schools in terms of the empowerment and all of those is part of that. The more that people don't end up abusing alcohol and drugs every weekend, especially at the end of the month, the first weekend of the end of the month, you can go to Khayelitsha without even looking at the hectares of the system. You see all of these blood and everywhere on the floor. You see there like that, which is happening outside, and so forth and so forth. So starting from there, the social determinants of health is the ones that now the new South African system, financing system, it should consider putting money on the social determinants. And the other social determinants that probably might not see is about when you have got in some areas, I'm not saying encourage, just an example is about where there's might be high level of the diarrhea among children, or to find that probably is poor sanitation or food handling and all of those, or mixing of the baby formulas, kind of those things. So when we prioritize as per according to the disease profile in that area. And then we make sure and use the system. In Khayelitsha, actually, even when we were during the middle of the HIV AIDS, when we did the seroprevalence of those people, part of the vector program, so that we determine the linkages between the risk factor and also COVID. And if you are diabetic, we have done that already as part of that. So yes, indeed, Member Benfocha, I'm not disputing that patients will be on the floor. They will be on the floor. They will be on the floor because the hospital will never be able to accommodate not only the numbers, but the disease profile that is there. It will always be like that. That's why I'm saying that Did you go upstairs to the psychiatry ward? If you would have gone there at the time, the last time I was there, we even have to remove the beds and then we put it in a mattress so that to accommodate the space, because so many young people, mostly the males, who are full there. Similar actually in New Somerset. At last time that I checked, it used to be about the 15 bedded, where you end up having one time 40. It was, I think, during the Christmas and whatever. It looks like every young person smokes or get drunk during the time. 40. It's too much. And I don't see any health professional who want to take care. I mean, what to call it, the passage kind of taking care of it. They don't want that. No one wants to do that. But the circumstances, the social factors that are happening there, it's more than the people that can do. I remember one professor who was the head, I can't remember another name, at GSH, when she was talking about the trauma cases that they see from the gunshots, multiple gunshots of the young people they have to save. He said that they're actually using the battlefield medicine, because if you're still going to take longer to take the patient to the theater to stop the blood, it may take longer. Sometimes they were showing things like a straw where immediately just to stop the blood whilst they are pushing them to theater. And I've seen some of these young people who had 42 gunshots and they're still surviving. So it's not nice even among the healthcare workers. Yes, indeed, you'll see patients on the floor because there's nowhere else. Unlike in the school, when you bring the child for enrollment, the school can say, you are full, go to another school. When you are staying in a shack or outside in a plastic and then you want a house, they'll say you are number 550. But I don't have a house, but unfortunately you have to wait. When you apply for the social grant or want to review your disability grant, they'll say, wait, we're busy with it. Unfortunately, with a hospital, you cannot say you are full. Because you are full, you can't. It means that we have to keep on opening, and therefore you have to do the triage in terms of that. The first one who's red, that's the one that needs to be assisted to save lives. The one who's green, unfortunately, you might have to wait for 8 hours. That's how things are. It's beyond us, because what is happening, the whole thing is happening outside the health system, and we don't have much of the money. And what is worse now, 2 billion that will have a decrease in the outer years, because in Gauteng and also us, where they are saying that in regard to the equity, must give more money to other poor provinces, where there's a fewer, at least for them, who are more people who are not insured and so forth. So it's beyond us. So we do understand, but we have to dollar whatever it must in order to save lives. But we don't have such money around that. The CFO mentioned about even the issue of the staff numbers in the outer years, where actually they all have to decrease. Just imagine, like now, the ones that we are finishing, who have been on contract for the COVID, we have to let them go. Just even the whole country, where you'll find that we have got doctors who might have completed their internship, but even for their community services, but it cannot be appointed, but we need them, but there's no money. So whatever we have to do things so that things can work. So that's where things are in regard to that part of it. So as I indicated, that it's not only Khayelitsha, because as I'm saying that, talk about serious where they have to queue outside whilst they are waiting for something, but it might be different kind of a situations, because each and every area is being affected by the other area. Thank you, Judy.
Thank you, Chairperson. So I'll just answer Member Baku Foss's 4 questions together. So on page 222, Member Baku Foss's first question is, why is the Provincial Revenue Fund decreased in terms of the allocation? Point 2, the national equitable shares increased by 8.10. So the provincial the Provincial Revenue Fund is reduced by 86%. If you then go to page 224, which is the third question, why is there a reduction in administration, which is 10%? And if you go to page 225, the maintenance and repair, that there's a 7% decrease. I'm going to ask Mr. K to answer all 4 of those questions together, because it's got to do with funding flow. and allocations in terms of our system. So to answer all four of that, Mr. K will give you an answer of what the financial flows and all of those are. If I then come to Member Windvogel's questions, I think the issue of Khayelitsha Hospital, Minister has addressed the issue. And we're really asking the committee and Member Windvogel, everybody, to work with us to find solutions for Khayelitsha. But it is to work with us to find solutions which is durable and sustainable solutions in terms of fewer people having to present to hospitals. That has to be the focus of what we want to do in Khayelitsha. If I go to the PPHC fragmentation question that Member Windvogel has asked, we have been on record for many years that the Western Cape government's position is that primary healthcare services in the metro, in the city of Cape Town, should be under one authority, and it should be under provincial government authority. We have commenced processes with our city counterparts. The minister has met with the MACO member, and we are currently looking at a phased process for consolidation of services, the fragmentation of the governance to be under the Western Cape government. So there is processes initiating, and there is specific plans of how we will do it in a timelined way. In terms of the G of Jooste question, we're talking about Klipfontein Regional Hospital replacement. There has been, at the last meeting and the annual report, we gave an answer in terms of why there was a delay with the allocation of a tender. So what we're now doing is we're working with Transport and Public Works. The tender has been published. The tender will be allocated, Mr. K, in May. And once the tender is allocated, Member Windvogel, it is really to then start with the process of in the stages with the planning for phase 1 of Klipfontein Regional Hospital. And we have a clear schedule of what the activities will be from April this year until March the year after. So that is a very clear schedule, and we're working with our colleagues. And as Minister Mbombo said, we've prioritized 4 key things. The Premier referred to 2, which is Klipfontein and Belhar. And so as we complete and get the schedule going for Klipfontein, we also want to give the clinical brief to our colleagues in Public Works to also go on to tender as a next step for the Belhar Regional Hospital. It will go just after Klipfontein. And then we have 2 additional priorities that we have put on in our colleagues with him. There's no financial allocations to it yet, but we want to speed up that. And that is a Helderberg Regional Hospital. That's our 3rd priority. And then the 4th priority is the replacement of Swartland Hospital that was in the fire. So we, with Public Works, have agreed that that is our 4 catalytic projects, and we need to move with that with speed. But I'm raising it with you because Klipfontein Regional is the front of the queue of those 4 institutions, and we have processes in relation to what our commitment is. If I then go to Member Plato's question, I think, Member Plato, we are fully familiar. There is a system that we have in our infrastructure. It's what is called the facility assessment system. So the facility assessment, you say how appropriate is this facility? And there's a scoring system on that facility assessment. So we have a complete list of all the clinics which we need to refurbish, upgrade, or replace. So we have it for all the facilities in the Western Cape. Obviously, the risk you're asking, what's the risk associated with this? There's an additional risk about suitability, which is about fire risk in terms of that facilities as well. And generally, we are looking at the places with highest pressure, and we have a prioritization exercise in terms of where the highest pressure is so that we have a schedule of maintenance. So Mr. K can also refer where in our schedule we then talk. So the budget item that you're looking for schedule of maintenance is 8.1. So there's an additional annexure, and the 8.1 gives you the details of what money we have in the metro and rural for that. Now, obviously, when we have the city conversation, there's also a conversation about the suitability of facilities which are city-owned. And there's some of those facilities where it's city-owned, but we render the service. And there's some facilities where it's city-owned, but both of us are in the building. So we also then work in partnership with Transport and Public Works with the city about the appropriateness of the facilities and the upgrading of the facilities. And then Member Philander, I think the point Minister raised the issue. I think if I can give you this answer, we work in a decentralized system. So we take all the health facilities that we have and we divide them into 8 geographic areas. And that is the 5 districts outside in the rural areas, but we do Garden Route and Central Karoo together. We go Overberg, we go West Coast, and we go Cape Winelands. In the metro, we divide the metro into 4 areas. That's the substructures. Each of those management teams have to have an understanding of what is the healthcare needs in the various geographic areas and the various facilities in their geographic area. We take our lead in terms of prioritization of those teams. What is the priority in each of those geographic areas? So that way, there is not we prioritize Tygerberg Northern, but we don't spend any money on Klipfontein or Mitchells Plain, or we don't spend any money in West Coast. We have in each geographic area a prioritization process. And that is what I've just explained to Member Plato is there is facility assessment, there is movement of people. So one of the colleagues this morning, our meeting from 8 to 9, was just saying to us, and the Minister, I'm sure she's knows about it, but there's just been so many undocumented people in an area just outside between Robertson and Ashton. That has just exploded in the last 2 months. So that Cape Winelands team might have planned for something. All of a sudden, there's a lot of people between Ashton and Robertson. Now we have to plan and see how do we adjust our plans, but it comes out of the Cape Winelands prioritization. Whereas we know Cape Winelands grows a little bit faster, second to the metro, then would be in Overberg or in West Coast or even Garden Route and Central Karoo. So I'm just giving you a sense that prioritization comes out of that. There's something called a district plan, and there's very much clearly from that level, we are asking, and we're going to now really on the back of COVID, really move on it. It's at that level that we want that district manager, expectation of them. It's a very difficult job. I mean, I can tell you there's very difficult jobs in government, but to be a district manager in the Department of Health at director level is an extremely difficult and complex job. And that person is expected now to understand all these needs that comes at them, and then all of a sudden deal with all the social determinants, and then go to all the other sectors and say, please do this so that we can turn the tap around in terms of the diseases. That's the expectation of that manager. And we have to work with them to strengthen their arms on the back of COVID, to be able via district, the JDMA, with municipalities, with all other sectors, so that we can identify the hotspots in each of those geographic areas. Where are people growing? Where is the need outstripping the demand? And how do we respond? By working with other sectors in that regard. So if you ask me what's the strategy, our strategy is to strengthen the arms of those specific people to be able to do it, and then help them from our side to enable the processes to go. I'm going to ask Mr. Kay just to respond to Member Bakufos's technical issue of the allocation on the 4 points. Thanks, Simon.
Thank you, HAD. So there's been a little bit of a change in the mix of where our funding has come from. So the Provincial Revenue Fund primarily last year was around our COVID response and provincial priorities. This year, that money is being funded not at a provincial level, but is coming through the national equitable share allocations. So that's the primary reason why you see one go down and you see the other one go up. We look at the bottom line items. The question on the budget cuts in program 1. So the reality is that our COVID allocations have decreased year on year. And in fact, if you look at the asset reserve, the increase in the asset reserve, you'll note that in the 2021-2022 year, it went from 1,014,000,000 to 1.25 billion rand. That was as a result of us using our savings from the previous year to fund COVID activities in this current year. The COVID activities have decreased in terms of funding, and you are seeing that showing itself up in the admin sector program 1. Primarily, It is a reduction in the amount of money that we are spending on testing, not necessarily a reduction on the number of tests that we are doing, but there is a rate change. So if you do a PCR test, it costs you 500 Rand. You do an antigen test, it costs 120 Rand. So you can do kind of 4 antigen tests for every 1 PCR test on the rate basis. So we've decreased that. And the other thing that we've done in the admin sector is we've taken the PPE budget, and we have taken it out of the center because we've got a warehouse with stock, and we've given it into the facility. So it now sits, that budget has now gone to program 2, program 4, program 5, and some into program 3 for EMS, for patient transport. As Dr. Kluti said, so I think, and again, this is around the infrastructure. The wants and the needs are always greater than the funds. That's we'll say that again next year, and we'll say it again the following year. That's just the simple fact of the matter. And so it does become around what you prioritize. And Dr. Kluti is correct, and we haven't got there, but annexure, it's called the table B5, which is from page 273 through to page 287. Details every single project that we have got planned for the next 3 years, as well as the estimated cost in the future, as well, or the total cost, as well as the expenditure, cumulative expenditure. So one can then see how and where we have prioritized. You will also note that there is a slight change. It's not a fundamental change, and I would ask to, I know I'm taking us forward, but Chair, if I could ask on page, where was I? Page 249, table 981, shows the different allocations between goods and services, which was primarily repairs and maintenance, and then buildings and fixed structures, which is primarily capital work. And you will see that there is a decrease in the goods and services on the maintenance. That's because we've shifted it to do more work on the capital side of things. So it's a slight shift in focus, but the bottom line is still a very healthy 8.39% increase. And a lot of that has to do with the additional grant allocation that we got, the incentive grant allocation. We got about another 68 to 69 million Rand in that incentive grant allocation. Again, the details on the total costs of each of the major projects is there. So you can see the amounts that have been anticipated over the periods to be incurred for Klipfontein, for Belhar, and many other things. And also, if you look in that, you'll see the acute psychiatric units, for which Khayelitsha District Hospital is very much one of those where there's going to be an investment in that. I think that's me done. Yep. Thank you, Chairperson.
Thank you very much, Mr. K. Member Kegel, you still have a burning question?
Yes, it's not much. It was only on page 225 with regards to the infrastructure. That how far is the department with regards to infrastructure development plans in areas such as Tegabek Academic Hospital, and at what stage does is that department with that?
You are unfortunately not that clear. The sound doesn't come out too clear. Can you please repeat your question?
I say on page 225, Chair.
225.
Yes, with regards to infrastructure. How far is the department with regards to the development plans at the Tegabek Academic Hospital? If we can get a progress report as far as that is concerned. Thanks.
Was that Tygerberg Hospital?
Yeah, yes, Chair. That's correct.
The current? Member Kegel?
Yes, Chair. Can you hear me?
Is that a positive?
Yes,
Thank you
yes,
very
yes.
much.
So can I go ahead,
Yes, yes,
Chairperson? Thank
please.
you. So Member Klego's question around Tygerberg. There's quite a few things that are happening with Tygerberg. But previously, we were giving feedback on the PPP for the Central Hospital. So there's been some progress in terms of working on the speed of when the Central Hospital replacement will happen. And in the meanwhile, there's also been allocated maintenance money from Treasury to upgrade parts of Tygerberg Hospital. So if anybody is at Tygerberg Hospital, they can actually start seeing progress in relation to various parts being upgraded. So it's a combination of upgrading parts of Tygerberg, planning for a future Central Hospital, and then planning for the Belhar Regional Hospital. So you need to understand that all three of those run concurrently in relation to that. So the specific question is the progress, Mr. Kane. So the maintenance money, the PPP, and then the plans for Tygerberg Regional. And it is actually in the schedule, but it's understanding that you piece those pieces together because they're all linked to Tygerberg. Mr. Kane?
Thank you. So, yeah, it is let me just focus on the Belhar and the PPP, the replacement of the Central Hospital, because we're ongoing with various projects, and again, they're linked. They're articulated in quite a bit of detail in these documents. So we were finishing the internal brief, the internal clinical brief for the Belhar site. And in doing that, there was an understanding, because they're both linked, that the Central Hospital was going to have to pick up certain additional services. So it's about another, I think it's another 68 or 9, I think it's another 68 beds that must then go into the Central Hospital. That has therefore required that there is a rework of the feasibility study on the Central Hospital, because they both have to be affordable. And we have to both, before we get them go ahead, they both have to be fully funded. And so that feasibility study was circulated to us, I think it was last week. That will, we'll have a look at that. I think we're meeting again tomorrow on it. And that will impact the clinical brief that will then go through on the Belhar site. And the aim for the Belhar site is to have that clinical brief into the implement agent by the end of this month, so that they can start on the, well, not start, because they've already done quite a lot of preparatory work because of the lessons that have been learnt on the Belhar site. And so that's pretty much where we are at the moment. We still have got BFI funding secured for both Klipfontein and for the Belhar site. And also for the Belhar site, we have already secured the land. The land is already there, whereas the Klipfontein, there is still some work that has to be done with education, as well as the city on a whole range of issues in that particular space in order to secure the site. But for Belhar, we've got the site. And it will be ready to be built on. Because the other major complication in this is you'll have basically 3 hospitals that you're going to have to balance up. So we're going to have to be building the regional hospital, which is fine, that's on a greenfield site. But then you're going to have to decant the regional services out of the Central Hospital while still maintaining the Central Hospital as a teaching platform that is linked to the university, whilst then starting to build on the site that is Tygerberg, which is going to require a whole lot of demolition of certain buildings in order to create the footprint, and then eventually move and decant the services out of the current Central Hospital into the new Central Hospital. And you can imagine that that's quite a ballet dance that is going to take some time to get right. But that's really where we're going at the moment. Thank you very much, Chair.
Thank you very much, Mr. K. Members, at this point, we are taking a short comfort break. Department guests as well as members are welcome to have a cup of coffee or tea in the members' lounge. We are pressed for time, so we will be back at Thank you.
Member Regan.
Good morning, everyone again.
Is it Member Regan? Ellen?
Yes, I am still here.
Oh, we just want to check if you are still in the house.
Thank you so much for checking. My medical emergency is still underway, but I am present. Thank you.
Members, welcome back. We will now proceed with our meeting, and we are on pages 231 to 245. Any questions on those pages, members? I see Member Windvogel. I do not see any hands online. Please proceed, member.
Thank you, Chair. Chair, my question is on page 235.
235.
Yes. Table 9.3. I welcome the increase on that. Yeah, I welcome the increase on that point of reference on that table. What I want to know, Chairperson, is, however, what I want to know is how much of this budget will be spent on private ambulances and why, and how will it improve the waiting time and conditions in the rural areas, and how many additional ambulances will be procured this year. And then, Chair, on page 235, table 9.31, compensation of employees. What is the number of EMS staff members that are not permanent, and why? Then my last question, Chairperson, is on page 245, table 9.7. What are the reasons for decrease in funding for forensic services, and how will this impact on service delivery? Thank you, Chairperson.
Thank you very much, Member, and thank you for sticking to the 3 questions. Member Kego and then Member Baku Vos.
Thanks, Chair. I'm not sure if I'm audible enough this time.
Are you covered, Member?
No, I just wanted to check if I'm audible enough.
Yes, you are. Thank you.
All right. Thanks. Thanks, Chair. Mine is on page 239. No, let me start with page 234 on the emergency medical services as raised by Member Van Vogel. But what I wanted to check on the issue of the ambulance is that there is an issue about the how the ambulances respond, the response of ambulances to people, understanding that some of the areas are high risk areas, and also the issue of the availability of ambulance services. Now, people end up utilizing the private ambulances, and then they end up incurring a serious debt as far as that is concerned. So I just wanted to understand then, what is the department planning to do to assist in that kind of regard to ensure that there is enough ambulances that would be able to render such services. Then going to page 239, under transfers and subsidies, that there is a total of 3.8 million transfer subsidies to non-profit institutions. Now, what I want to understand is that how many non-profit institutions is the department targeting with regards to these transfers and subsidies, and how much will each institution receive on average, roughly? Then lastly, on page 241, my third question is the issue of the regarding program 6 on health science and training. With the issue of the absorption of personnel, that what rate is the department utilizing in terms of absorbing the trained nurses? Because even yesterday we had an issue where nurses who have trained and acquired some kind of receipt and payments that they have done that were due. And then what process are they supposed to be following these people in order for the department to absorb them? Because recently they complained that they've received information from the department that they are supposed to undergo some certain training and attain a certain certificate, additional certificate, in order for them to be absorbed. Just a point of clarity as far as that is concerned from the department side. Thanks very much.
Thank you very much, Member. Member Baku Vos, and then Member Allen.
Thank you very much, Chairperson. My question will be on page 242 in table 9.6. I would like to ask the department what are the reasons for the bursaries decreased funding, and how many students will be affected, including a breakdown for nursing students and doctors. What is the total budget for medical interns and whether all interns have been placed? That's my first question. And the second question is on 248, on table 9.8. What are the reasons for the decreased funding for district hospital services and other facilities, and which project will be affected? My last question will be on page 265, which is in table 8.4.
Member,
I would like to know what are the transfers. Yes.
Can you just keep that one?
Okay.
Because you are already then in the annexures.
Okay, thank you, Chairperson.
Thank you, Member. Member Allen.
Thank you so much, Chairperson. I know earlier on already it was addressed regarding the TB matter as well as the psychiatric need in our province. I wanted to refer to page 237. I note in terms of sub-program 4.2 that there is a allocated amount, but specifically on the psychiatric hospitals, that increase of 35.9 million rand, would we be able to get an understanding of that staffing resources will be needed, will be met in that regard with that amount specifically, considering the need? But then I do want to echo a sentiment that this committee expressed on page 244 in terms of the forensic pathology services. Chair, I am delighted to note that the operational plans for that is going to be concluded in the 2022-2023 financial year, as we have discussed that in our committee, and I note that this will assist in a quicker turnaround time in cases requiring examinations. Thank you.
Thank you very much, Member Allen. Minister and HOD.
Thank you very much, Chairperson. So I will take it on the pages in terms of where the members put their questions. So we'll start on page 234. So it's Member Tleko's question on ambulance response times, especially as it relates to high-risk areas. So just to indicate to Member Tleko that there is quite a few compounding issues in terms of dealing with the deployment of ambulances and the response times to where people need the ambulances. One of them, I think Minister Mbombo referred to earlier, is when we have periods where we have a big demand for ambulances. And because we have had data around violence and injuries, it makes a lot of sense to us now, because we know that every weekend from Friday at 6 o'clock the evening till Sunday midnight, there's a massive increase in trauma and violence. So you need to understand that our deployment of ambulances then in certain times, which is the same thing that affects Khayelitsha Hospital, it's that spike in trauma and injury and the request for ambulances goes up disproportionately in that period of time. So obviously one of the things we have to say is, how do we deploy our ambulance capacity? And what happens is, at the peak of that, which normally runs into a Saturday afternoon between 2 and 5, is that there's such a backlog on Saturday afternoons. And it's something that I've now noticed. A lot of people write to me about ambulances waiting. It's invariably always a Saturday running into a Sunday morning. And a couple of weeks ago, there was also the call center went down and it was reverted to another place. But be that as it may, the one big thing is the weekend peak. And then it's worse on a month-end weekend. So if you put all of that together, the demand and the calls for ambulances is not even through the whole week. There are certain peaks and certain times of the month where it goes up disproportionately. So if you are a member of the public that has a heart attack or has anything in that period of time, it is that you then disproportionately wait longer than it would have been on a Wednesday afternoon at 4 o'clock. That is the one phenomenon. The second one is the 4 waves of COVID exacerbated that as well. So now you have the violence and you have those peaks, and then you have COVID in peaks also doing that. So one of the things that we now need to look at, and that goes back to Member Windvogel's questions, is How many ambulances can we get on the road? How many will then be deployed metro versus rural? And how many staff members do we have to do that? And how many of them are contract staff in relation to that? So we put all of that together. Dr. Karim and his team, Ms. Arendse, and we've just appointed a new director for EMS. The big strategy for them in the recovery is how do we do all of that differently? And especially how do we bring in additional capacity for the predictable peak periods? In COVID, we learned one lesson. We could bring in additional private ambulance capacity that we contract in to help us with peak periods. That has worked extremely well. There is also a second thing, and it's a very sad thing. It's one thing if we have the ambulance on the road that can run. Another thing is, do we have the crew that can man the ambulance? We have a shocking statistic that there is such a big proportion of our ambulance staff members that has been so traumatized through all the episodes that a lot of them cannot actually physically go back on the ambulance. They are doing office work. So that is another thing that we need to say. Now we have EMS staff, but not all of them can be deployed because of post-traumatic stress disorder. So that's the second thing. So it's one thing to say, how do we get ambulances on the road? Another thing is to say, how do we get the right mix of people that can be on the ambulance? Which then includes, Member Van Vogel, that you actually have members that are permanent staff, but they cannot be on an ambulance because of the trauma and stress suffered before. But then you have contract staff, and we can't make them permanent. So it's really about us in the department looking at how do we bring relief in the EMS space by moving the staff members out that cannot be on an ambulance into other parts of the department. That frees up the space for people to then look at their staffing in terms of that. And obviously what we will do is we'll do it in terms of fairness. The same zones. Metro will be 4 zones. Rural is in the districts. And it's understanding what is the optimal deployment across all of those, with a mix of basic ambulance, with these contract workers potentially becoming more permanent, and then also your more advanced paramedics, and putting all of that together for a solution. Dr. Karim, I don't know if you want to add anything to that, but that is the EMS situation. Dr. Karim?
Sure, thanks, HOD. I can just add to that. On average, we have about 250 vehicles on the road. And most of the majority of that obviously is in the metropole. And there was a question, HOD, on the private ambulances. So we've spent those thus far for this financial year past 19 million, roughly about 19 million on outsourcing for private ambulances. Added quite a significant amount to the service platform. And for the following year, we'll be talking in the question, we've allocated an additional 5.4 million already. And obviously, we'll see how that 5.44 million rolls out and then make a decision later in the financial year whether we need to allocate more resources, because we obviously expect the COVID pressure to decrease over the coming financial year that we're talking about, 22-23 in other words. So now in summary, 250 vehicles on the road, majority in the metropole, and in summary 5.4 million allocated in 22-23 for outsourcing of private vehicles. And that's from that additional reprioritized allocation that we got from the funding. Yeah? Yes. Yeah, and one of the focus areas, Mr. K reminding me now, of the 5.4 would be specifically on maternity services, because we found that that's a really important pressure point.
So there's a geographic focus, there's a time focus on what the pressure areas are, and then there's also a type of transport focus. And what we specifically wanted to do is to make sure that pregnant women don't wait, so that we speed up. There's something called the flying squad process or ambulance. So if a pregnant woman has to be transported because of the danger to her and the baby, that gets prioritized amongst all of that. So that is the total picture of all the EMS interventions. If I can then go to the next page, would then be page 237. Remember, Alan asked the question under sub-program 4.3, the psychiatric hospitals. There's 35 million added under psychiatric hospitals. So you have to understand that this is one part where the psychiatric pressures are. Now, the psychiatric hospitals we're talking about here is specifically Stikland, Valkenburg, and Lentegeur. Those are the three specifically that we're putting additional money in. And you must remember they are so if Khayelitsha has a lot of psychiatric patients, it is the ability of Lentegeur to admit more psychiatric patients to take the pressure of Khayelitsha. So that is how that links. It is the ability of Falkenberg to take more patients, to take the pressure of Somerset Hospital. And it's the ability of Stikland to take the pressure of Karl Bremer Hospital. So you need to understand that that is what this is. It's mainly for staffing, and it's for staffing to help with the acute pressure of decongesting places in there. But also what is very interesting, like we had feedback from the Ms. Olkers this morning in the Mitchell's Plain situation. That's the top end is to make sure people are admitted into the psychiatric hospital. But what they've achieved in Mitchell's Plain was also to say, actually, it's not just Lentegeur taking the patients, it is also fewer patients coming in, which is back to the Khayelitsha conversation we've had. It's really working with community health centers, PHC services, community rehab services, substance abuse interventions, so that fewer people then get admitted into the district hospital. Because the pressure point is the Khayelitshas, the Karl Bremers, the Somerset, the George, the Paul, the Worcester. That's the pressure point where people come. So this is a release valve on the top end, but there also needs to be community-based interventions to release the other way. So that is on page 237. If we go to 239, so Member Kleko is asking a specific question, and that is the 3.8 million allocation to NPOs. There is a schedule, and that detail, not sure, Wilna. Sorry? 227. Backwards. So it's page 227. Oh yeah, so that's page 227. That's all the details of all the NPOs that we are referring to on that specific table. But this is a program 4 one. Eh? Remember, this is that's the vote. Yes. Okay, so this is the vote in terms of all of that. So the detail, Member Kleko, is actually on the page 227. So there's obviously NPOs ranges from an NPO that houses community health workers to an NPO that has mental health license home for mental health clients with intellectual disability. So there's a range of NPOs we give money for. And there's a big spread of all these NPOs across all the areas. If you then go to page 241, that is Member Kleko's question about absorption of trained nurses. So just to explain to Member Kleko, we train nursing staff, we train medical officer staff. There is a statutory obligation, once they're trained, that for medical staff, they need to have their internship and Cosmo years completed. That's a statutory obligation. For nursing staff, once they're trained, there's a statutory obligation that we need to give them access to community service training. Once you've finished with community service training, both doctors and nurses, you are a qualified professional that, like any other professional, must apply for a job to get a job. Now, that doesn't mean it has to be in the state. It can be in a private institution. You can go wherever you want to work, but it is, you enter the work of employment. So you cannot come in a community service position and have an expectation that you automatically get absorbed because you have qualified and the state has done its obligation to you. You then enter the world of work. And it means you have to apply for available posts, and there's a process. Now, there is a very clear process where all community served nurses are actually guided on what the process is. You must apply here. This is the available post. There's the vacancies. When I qualified as a doctor 30 years ago, that's the process I have to go through. I have to look for availability of posts and I have to apply. That is the process. So there is not an automatic absorption of somebody for which the state has finished its statutory obligation. There is the creation of job opportunities but it's incumbent on the person to apply, like anybody else, to enter the job market in terms of that transition. So if we then go to next page, which is 242, Member Baku Vos is asking about bursary decreases. So just to talk about bursary decreases in this, I'm going to ask Mr. K just to kind of give the detail in terms of a very nominal decrease in bursary allocation. And it's got to do with our criteria for giving bursaries and who qualifies for the bursaries. And it's a spread between nursing and doctors and all other categories of staff. So there's a clear bursary program. Just also to clarify for you, our bursary program is based on the criteria of need. Anybody that lives in this province that wants to study as a health professional can apply. But like everybody else, it's an application process. And the people that qualify then gets allocated. Part of the problem is if you don't pass your years, then you forfeit your bursaries. And that is the issue about you can't have an expectation that you have a bursary, you fail, and then you continue to have the bursary because for people that need to come in, those are the criteria that's built in. Once you've qualified, this is the part of, because you've qualified and you got a bursary from us, and you've done through the statutory obligation, so you've done your community service for both doctors and nurses, because you've taken a bursary from us, you have an obligation to work for us. So therefore, when we have those vacancies and you apply and you're a bursary holder, you get preference over people that doesn't have bursaries because you have an obligation to work back the money from the bursary that we've given you. So that is what the process is. In terms of medical interns, does not fall into this at all. The medical intern process is a statutory placement. It's managed from the national department. So everybody that becomes a final year medical student that needs to be placed into an intern post has to apply to a national process. The national department places all medical interns, and this province and our institutions is part of the platform where they get placed. All the interns have been placed because the national department got additional resources. We have indicated that we cannot take additional interns unless we have money. So we've got some additional allocation for interns and for community service doctors, which allowed us to increase our intake this year, but as part of a national program in that regard. In terms of page 244, let's get this right, 244, Member Allen's question about new observatory forensic pathology institution, that it will become available and operational during this year, and it will take off significant pressure. So we're all looking forward to it, that we can start occupying this space. It is a very modern, and it's a completely different space to what's currently at Salt River Forensic Pathology, and it will give us the capacity to expand service on the Metro West side. Then on page 245, Member Windvogel was asking the issue of forensic pathology, forensic services, the 0.33% decrease. Mr. K, I'm just going to refer that to you because there's probably a reason why there's a small decrease on the 0.33. It's stable 9.7. So I'm referring that to you. And then I think Member Baku Vos went to 248 and then asked a question of why in the health facilities management allocation, the district hospitals, which is 0.3 as a 17.22 reduction. Again, Mr. K, I will just refer that allocation to you, table 9.8. Chairperson, I think that's all the questions. Mr. K?
Thank you, Chair. So the bursaries, again, not necessarily be comparing apples with apples because there was rollover funds that were given for exactly what Dr. Kluti said. Some people passed, some people didn't, and so it's a timing issue. You'll also note that in the table, I was looking at it now, page 260, you'll see there's also adjustment with internal bursaries. So there's a restoration of internal bursaries as opposed to this year. I was just looking, the total number of bursaries are going to be 1,420, which across the board, which is around, it's very much the same kind of number year on year that we do. Then on the forensic, the PFS, so you'll see on page 245, we've been investing quite significantly into the Salt River facility. The group have been progressively filling that budget. The important thing to note is you see 2021, we went from 214 to 242, and then up to 245. So there is an incremental growth. It comes down slightly because there's a budget of number of people that they're aiming to appoint, and then there's the actual number of people that they've appointed. So it's a slight difference. And then the other thing that we've also got is there is, I think, an additional 18 million rand. We are looking to fund that in year from other places, other potential savings. But again, we're not going to provide the budget. We're rather going to suggest that they find the people. When they find the people, we'll give them the budget, the additional budget from a baseline allocation perspective. Then table 9.8. 9.8. Okay, so again, this is the infrastructure. So I think I've indicated in earlier questions about some of the strategies around infrastructure and the mix of facilities and the priorities. So this is just a representation again of the B5 annexure, which is pages 273 through 287, where the specific details are per sub-program and per project. And then one can see the movements by and between and how these numbers ultimately arrive at themselves. I think that's it. Thank you, Chair.
Thank you very much, Mr. K. Members, can we move on to pages 246? Member Bakufos. Member Bakufos.
I would like to ask a question from 229.
229, we've moved on, member. We are now done with that section.
I mean 248. 248.
We now 246 to 241, so 248 is well within that. Yeah.
Chairperson, can you repeat yourself?
Member, on which page is your question?
No, sorry, Chairperson.
248, as I said.
I referred it to Mr. K to answer. There's on table 9.8. There's a question from Member Baku.
Outstanding.
It's an outstanding question that he must say, why is there a decrease against district hospital?
Thank you, HUD.
Sorry, Chair, I thought
by 265.
Member, there is apparently an outstanding question of yours.
I must answer first 248. My outstanding question, and then I want to ask.
That is why we prefer to be in chambers today. We're really missing each other now. There's an outstanding question.
The reason I'm speaking, you are speaking to.
Or can we leave that one and move on to pages 246 to 251? Do you have any questions, Member Van Vogel, on that pages?
Chairperson, you recognized me. I'm waiting. I said I want to ask 248, followed by 265. I didn't hear your response.
I responded to you by saying there was still an outstanding question, but you can put that question in writing. I will then now afford you the opportunity, member, as you indicated that you have a question on page 248. Please proceed.
Chair, if I may, there's still an answer.
No, member is referring to another page, so we're not gonna go to that answer now.
The department didn't give an answer. There's
think
also going to do it now.
Are not concentrating in the meeting. I didn't receive the response from the department.
You did receive it?
No.
That is what I'm trying to ask, and you go to 248. Okay, please let us give the department an opportunity to respond.
Thank you, Chairperson. The question was why on table 9.8 under district hospital services, the amount decreases by 17%. Mr. K gave a general answer. I'm just asking him to explain explicitly that specific part.
Thank you, HOD. So my answer was referring back to the detailed schedules in terms of pages 273 through 287, where each of the specific projects are listed and the classifications are listed, because with capital, it's a once-off. So it doesn't mean the expenditure that you incurred in this particular program in this year, you're going to incur exactly the same in next year. Now, I mean, we can go through each and every one of the details if you want, and if that's something that is requested in terms of a written question, we can respond to that. But I'm saying that the basic principle and the detail and the classification are found in these particular annexures and lists them accordingly.
Thank you very much, Mr. K. Member Winvogel.
Chair, let me then ask on page 265, because that's where we are. Am I right? From
246 to 251.
Yeah. Table A4, the provincial payment.
Which page is that, member?
It's 265.
We're now with 246 to 251. We're not yet dealing with the annexures.
Oh,
yes.
I have a lot of questions to ask.
Member Bakufos, I see your hand. Member Tejo.
Yeah, thanks, Chair. Mine is on page 248 regarding program 8 on health facilities management. I just wanted to check in terms of now that we're seeing we're back with the load shedding trends, and of which this is not the problem of the department, but it impacts directly to the service delivery of the department, the issue of load shedding. Now, I wanted to check in terms of facilities management, if our clinics have a backup power generators, and if not, if they form part and parcel of this upgrading of facilities and managing them in ensuring that we deliver quality service to our people as far as to facility management is concerned. Thanks very much, Chair.
Thank you very much, member.
Thank you, Chairperson. Just to answer Member Tleko, we have a very extensive program of assessing each health facility and the zones or the areas and their vulnerability for load shedding. So if you come to the hospitals first, there is negotiation with Eskom to minimize the load shedding for hospitals because of the impact it has on hospital services. So in many instances, there's agreement with Eskom that, and the City of Cape Town, that load shedding spares the hospital. both public and private. So that is an agreement, it's a long-standing agreement. Where there is the situation that hospitals have to be load shed, we have generator capacity at each of the hospitals to carry whatever the workload that is essential to continue at each of the hospitals. Our infrastructure colleagues must make sure that the generators are in working condition. There's regular checks that it works. And the big thing that comes with that now is diesel capacity to be able to run the generators for the times required. So all of that is specifically covered and maintained across all the hospitals as part of their disaster readiness for each hospital. When it comes to community health centers, there is a process of then deciding that each community health center should also have the same generator capacity and then the diesel availability to be able to do that. So in short, the answer is we have a very clear contingency plan for all healthcare services to continue without disruptions. The difficult thing is to maintain that at all small facilities. So there are disruptions. There's a size of a facility where it becomes very difficult to maintain all of that. And for the smaller facilities, there's contingency plans in each of the small areas to be able to do exactly the same across everywhere. So we are generally looking at the impact of load shedding and mitigating for it in terms of a very detailed program. Thank you.
Thank you very much, HOD. I see Member Baku Force's hand. Not? Thank you.
Chairperson, it's an old hand.
Thank you very much, Member. Please take your old hand down.
Please. I need to take it down. I will take it down now, Chairperson.
Thanks so much. Members, we are now dealing with the annexures, and can I please ask that we keep this one as swift as possible so that we still allow time for members of the public. So I'm going to propose that we are now 7 minutes before the hour of 12. If we can utilize those 7 minutes to attend to annexures 252 to 287. Should you have any burning questions on them? I see you, Member Van Vogel.
And mine is up to.
So we are in annexure 2.
Pages 252 to 287. So any question you have on a specific page, you can just indicate to that page.
Yeah, Chair, I only have one question on page 265, table A4, the provincial payment.
265?
Yeah.
A4.
Yes, by district and local municipalities. I don't want to make assumptions, so my question there is, what are these transfers for, and what are the reasons for the budget cuts for various municipalities? Thank you, Chair.
Thank you very much, Member. That was short and sweet. Member Baku Force.
Covered, Chairperson.
Are you covered? You covered, Member?
Yes, Chairperson, I'm covered.
Thank you. Thanks so much, Member. That is the only question then, as indicated for pages 252 to 287. Thank you very much. Minister or HOD?
So, Chairperson, this is a requirement of the schedules, and we have to break down what is called provincial payments and estimates by district and local municipality. So, Mr. K, you can explain the technical part of this. It's provincial payments by municipality. So you will explain technically what that means. Mr. K?
So thank you, HOD. So this is done when we go into the BAS system. This is done by responsibility, a regional identifier. Sorry. So it identifies the geographic area of all of our budget allocations, and then allocates accordingly. And this then comes out. What I will comment on.
So maybe if I can just qualify that.
Yeah.
So just, Chairperson, it's a technical issue. This is our entire budget of 29 billion.
Yeah.
And it is where the money is spent. This is not to the municipality.
Okay.
That is the technical explanation. So it's our entire budget broken down into, is the money spent in the city of Cape Town? Is the money spent in this area, that area, that area? It's not a transfer to the municipalities.
Thank you very much. You covered then, member. Thank you very much.
So just to add that, if you read the district health plans per every district, and also for the metro, which is normally for the rural, the district mayor signs, you find that they do reflect on this, and they can be able to zoom it in terms of that what is going to be done by each and every area, so that you don't get surprised when you say, I want a clinic in Swellendam, and then you said you can't, because they already, the local councillor who represents Swellendam in Overberg already knows in terms of what's going to happen for this year.
Thank you very much, Minister. Members, your time is up. I saw at the back, members will now again speak when we do our recommendations and resolutions, once we have excused the department members of the public. I see the minister is seeing hands online, but it's no hands. Only old hands.
Oh, my hand was up, Chair, but it's, when you said we
No, member, your hand was not up.
it was up, Chair, but it's just that when you said we are going to the public, then I withdraw it.
Very quick, member, do you have a question on one of the annexure pages?
Yes, Chair.
Which one is that, member?
Yeah, it's on page 267, Chair. It's about my constituency where I'm coming from. The regarding the provincial payments to district and local municipalities, just what the minister was now explaining, but I just wanted clarity on the issue of garden route. I've noted that there is a budget cut for the 2022-2023 compared to the 2021-2022. I just wanted to understand what could have been the reasons and the rationale behind that, so that when we go back to our constituencies, we're able to explain that. Thanks, Chair.
Which constituency were you referring to, member?
Now, I'm saying my constituency is garden route. So now I see there is a budget cut for the 2022-2023 on table 4A 4.2. Yeah, the issue of garden route, why there is a budget cut for the year 2022-2023 compared to 2021-2022. That's what I'm asking.
Got that one actually. Okay.
So again, this issue is about all our money that we spend in these geographic areas. But you now need to understand that this is district health services. So it's a subset of the total budget. It's not all the other things involved. And in this case, what you see is that because of the COVID money that Mr. K was talking about, a lot of what we saw, what is happening with Program 1, and we're taking money out. Because of COVID, we have adjusted what gets allocated, because across what goes to everyone, there's less COVID money in our system. So the answer to Member Tleko is, we gave more money for COVID for garden route, and therefore it is disproportionately decreased in that area.
Thank you very much, HOD. Members, I now move over to our session to afford members of the public to raise a question or make a submission. Way in the beginning of the meeting, the gentleman, his hand was up already. Is it Mr. Sylvester?
That's correct. Thank you, Chair. I felt very disappointed this morning because I was here at 7 and I was sitting and not a drop of water was given to me. The other thing is this, as the discussions went on, I only heard just before we went for tea that about Klipfontein substructure. How do the budget include us? And about the clinics, and also because I'm from the old school, and technology-wise, I expected a hard copy of the budget, which only arrived at 11:10, and I had to go get it from at the back. So this wasn't even given to me. That's my take.
Thank you very much for your input, Mr. Sylvester. Perhaps the procedural officer can just give insight as to the availability of the documentation after yesterday.
Chair, the documents, we only received them yesterday. Via the link, I did not have the hard copy as well. I only received my copy while I'm sitting here. So I think it's because of COVID and other challenges, maybe. So we get copies.
Yeah. Apologies, Mr. Sylvester. We will certainly try to do better next time and make sure that the documentation reaches you in time, as well as for you to afford the opportunity to prepare yourself for the session. So we note your question in relation to Klipfontein and the budget pertaining to that. Is there any other member that would like to raise a question? Ms. Kivitz? And then is it Mr. Costa?
No, Khalima Isaacs.
Khalima Isaacs, my apologies.
Thank you for affording the community the opportunity to engage the department as well as the portfolio committee. I think the first thing I would like to say is that we have an outstanding matter that came up in 2020 with regards to the clinic committees and the department and the portfolio committee. That has not been addressed because of COVID, but I would appreciate it if the portfolio committee could prioritize that as a next briefing. Because my comment on the Klipfontein Regional Hospital for the April 22 to 23, what engagement was there with the community? If we could prevent a situation where the community is not going to allow these contractors on site. We've seen it before as the department in Eerste River. So if we can prevent it, let's engage the community from the onset. That's my first comment. Then my questions, I've got three, and I would appreciate it if I could be allowed to ask the three. The delay in the forensic services at Observatory. I was under the impression in the previous APP that the services were going to be handed over in September, October of 2021. We in March of 2022. The delay in the observatory services. Then the Global Fund, sub-program 210. Who is the carrier of the Global Fund? And if there's a carrier of the Global Fund, was there an open process to how the Global Fund will be utilized and initiated? Then my last point is page 240, the current new policy priorities. Have Healthcare 2030 fallen by the wayside? Do we still look at the priorities we've set with regards to the 2030 healthcare plan? And if the plan is working, what role does community engagement play in the 2030 healthcare plan? Thank you.
Thank you very much, Ms. Kivitz. Mrs. Isaacs?
Thank you for allowing us this opportunity. As just to add to what Damara has just said about the Klipfontein Regional Hospital, I love right at the back of that hospital where the hospital is going to be put up. We as the community have had engagements in 2018, and that was the last engagement we had with the engineers, the planners, and those departments. But it's a very grave concern as the community, because the school is going to be built in the next couple of months. It's going to start. So we need to understand and make sure that our community benefits at the end of the day. We don't want another Chworster that has been stripped and been taken away due to the department who did nothing about that hospital. It was a very good hospital, and it was moved also without consultation with the community. So to add, that is just to add what the Mara said. We have had one meeting last year where the department came out to the community, and there was again a situation where we haven't been properly engaged, and we were just told that this is what's going to happen. We as the community doesn't even know what our hospital is going to look like. We haven't seen a plan. So as the health committee, we are not even part of that discussion, and we are nominated members as well. My next question is that we have the community healthcare workers within our community, and they get paid through an NPO. So a question would be, what is the possibility of them getting paid through government? And because we also have a lot of issues on the ground. Then I've been listening about the emergency services, how people get coded in the hospitals. There is sometimes when we know that the person has, because we have seen it, that the person has been given a green sticker, but then the person is sitting there with getting a heart attack or coming in with that pain. And they are being discarded as just a green sticker because it's a pain. But they don't really see it as an emergency, because if the person comes in and say that they are in a heart patient or whatever they say they are not being looked at and just given a green sticker and being put down there to sit there until they are being seen. And then the merging of the clinics, the city clinics with the provincial clinics, will they, in our instance, which is the Heideveld CHC, would there be extra staff employed to assist with the intake of the extra people that we would have, because we are also going to have a TB outlet, we're going to be having the baby clinic. So is this something that the staff would be complemented with more staff and admin staff, basically? Because if you look at the amount of people that we're already having at the CHC in Heideveld is to an extent where the staff themselves needs to struggle with day-to-day services. Yeah, that's it for me.
Thank you very much, Mrs. Isaacs. There is still one other. You wish to respond first, actually, and then is it fine? Mrs. Joyce Malebo.
Thank you very much, Lady Chair. Yeah, from Guguletu side, we as the community, we are very worried, because I don't know how long was it that we asked for another clinic to be built, because the day hospital we had is from in the early 60s, and the community has been grown, because we Guguletu is the only day hospital that is serving people 24/7. So the people are coming from the surrounding areas to the day hospital. how far are we, or how far are the department to look for a land where they can rebuild, or they can upgrade the clinic to assist the community? Because we had a meeting last week with the community, and the community are very worried and they want to take action because of the delay of the clinic that they are in need of. Thank you very much.
Thank you so much, Mrs. Malebo. I do not see any further hands from the guests. Then I give over to Minister Mbombo and the HOD.
Okay, thanks. The HOD will add some, but generally on the community participation, as we always say that we use the first priority is about the statutory obligations related to the National Health Act, and also with the Western Cape statutory bodies, facilities, and the clinic committees, of which is that part. Actually, we get every now and again in terms of the feedback, in terms of the progress where things. So generally, that one, I think we are very far much advanced when it comes to that. So when there is a space, we appoint. And thanks also to the community liaison officers, because each and every district has got outside metro. I mean, we've got those people who help with now the space that has been filled in already. Now that was left by Sean Stacy. So that has been filled. So we are able to do that. But noting that in between, you will always get people where they some of them might resign, or some of them might not be active. And therefore it drops the number of, or the percentage of the community members that are supposed to be there, because at the end, we wanted it to be a mouthpiece for the community, an opportunity for the community to have a voice. So therefore, at least the 50% that needs to be maintained, whether in the hospital board, whether it's in the clinic committee, from the community members, it has to be there. And then with the MPLs who are part of it, I think we've dealt with that part of it. I know that I've also signed the letter to remind the SC that we need to fill up the spaces now, as the membership in the legislature changes. It means that we have to also keep on changing, because some of the other people that were appointed, then they are no longer part of that. And then the other part. I think the issue of the now, specific now on the Klipfontein and community engagement. Klipfontein is part of the project that has been managed by the Department of the Premier, and also from the Mayor's side, City of Cape Town, as part of all other interventions related to the Manenberg precinct. What other interventions that are there or being proposed? It's the whole issue about the safety, which Klipfontein becomes part of it. So there's a whole issue related to schools, even having the, what we call it, the skills of schools, school of skills. The whole issue related to the community sporting, library for the whole thing about the youth, to create safe passages for the young people and everyone in the Manenberg. I know that the DICAS, they were still busy, also even the issue about the pool and everything. There must be safety around that aspect. And also, of course, and also other developments that are there. Now, the first part of it, the engagement that has been happening, it was the engagements with the steercom between the Premier, the then Premier, and also the mayors. That is part one. Where are we now in the Klipfontein? Because at the time that it was about where the hospital was going to occupy the space for the school, it meant that it's the education that must start the engagement in regard to for the school, because it's not part of us. They have to meet the School Act and all of those in terms of that when they go to the School of Skills, Skills of Schools. They are part of it. Therefore, for us, we cannot go and talk about something that is not necessarily there. As a result, for us, if you look in terms of at the back of the page there, you'll see that I think it's stage 2. So for any infrastructure, stage 2, we don't normally have community engagement on that aspect. Usually, especially when now I have to do the sort turning, it would have been around about stage 4, where they will have identified many other issues, because if it's going to be it's still a concept, or it's about the appointment, like currently on the professional services, it's still not part of the engagement. So it's still the other sectors that are busy with that engagement. So when the time is right now for us now for health, we will engage with the relevant audience that is related to the health. The others, what I know they've done, they started with a general engagement with the community. I know that from the Department of the Premier, and then they had engagement specifically with the school involving the principals and all of those and the SGBs. And then when time is right for us, we will do the engagement. But at this stage, we are not there yet related to the Klefontein. Over to you, Hishodi, thanks.
Thank you very much, Minister. Thank you, Chairperson. So just for Mr. Sylvester, asking about the Klipfontein budget, I refer him to table 9.2 on page 232. What you see on that table, Mr. Sylvester, is what we call Program 2. Now, in Program 2.3 is where lies all the money for community health centers. But this budget is for the entire department. This table gets broken down, right down to individual sub-districts. So Mrs. Olkers and her team will have, out of this amount, an allocation for Klipfontein, which will cover Gugulethu CHC, it will cover Heideveld, it will cover all the other facilities, the Nyangas and all of the other facilities, Hanover Park, all of them. So this is the table where your allocation emanates from. But when you come right down to each sub-district, and you can imagine we will have a table like this for Beaufort West, one for George, but as much there's one for Klipfontein. When we then go to Ms. Kivitz's questions, just to, I think, Chairperson, in addition to what the Minister said, there was a briefing session between the department and the Standing Committee on statutory bodies last year. So I think there's a question posed to the Standing Committee on what that is, and that's fine. But we had a briefing with yourself on the status of the statutory committees. But as Minister says, we now have a filled ASD, there's a process. And one of the things we need to come back to is an engagement. So when I talk about the engagement for the 29th of April, these are the kind of things where we need to actually have a discussion about what's the strategy, where do we take it. And we are very clear and excited, we've learned a lot, that we want to engage with the nomination process, the formulation process, and all of that around statutory structures. In terms of Klipfontein, the Minister's answered the question, because as I understand that the engagement of 2018 was with the steering committee, and it was from the Department of the Premier. That was the engagement. So between the Premier and the Mayor, and there's been changes between Premier and Mayor, and also, you know, Ivan Anthony and the guys working there. So as health, we are very much guided by our colleagues in the Department of the Premier, Department of Education, Department of Transport and Public Works. So a lot of them, because remember, a building that goes up in construction is actually done by Transport and Public Works on our behalf. So a lot of the engagements is from the technical side, from other departments, and we are just a participation. And as Minister says, in terms of the stages, there are lots of engagement. So for instance, the education and the school governing bodies and all of those, that's quite topical now. And there's a range of other things that should work through that same steering committee, as I understand it. So we need to take it up, but it's not us as health. We're only a participant, and it's taken up by these other structures. In terms of the forensic pathology delays. I'm going to ask Mr. K just to give you the reason why we have a delay. And mainly, in a nutshell, the delays is due to, because it was such a unique building. It is quite a unique building. It's the first of its kind. And to build it and to move in, it's almost like it's 99.6% finished. But the 4% is quite technical and it has to be gotten right. So the delay has been out of caution to make sure that everything is right so that we can move in without hitches in terms of that. And Mr. K can give a little bit of explanation, but that's the reason for the delay. In terms of the Global Fund, again, I refer Ms. Kivich to the table on 9.2, on page 232. It's very clear that the Global Fund program that was funded in this province came to an end in 1920. We reported on that on the annual report for this committee in the 1920 annual report. So as a department, that was the last time we managed a Global Fund grant. What has been replaced with is that there are Global Fund grants that's managed through the National Department of Health, and the National Department of Health then allocates money to principal recipients, but it's not us. So there's been allocations done to entities in this province, but it's got nothing to do with the department. What our oversight role of that is that the requirement from the Global Fund is that the oversight body is the Provincial Council of HIV and TB. So the council that's chaired by the Premier. So what we have is we have a report into the Provincial Council of AIDS. What's happening to the Global Fund money that's coming directly from the National Department to multiple recipients in this province. So the oversight is in that committee. And the COSA reports that houses this Global Fund Secretariat, I would imagine, sorry. The COSA then reports to the Council of AIDS and TB. But just to clarify, that is a national grant, and the money is for sub-recipients, which is NGOs. And the NGOs then accounts in the Council of AIDS of how that money is used. So the Premier and the Minister only has oversight together with all the other members of what's happening with that money. Just in terms of page 240, question about Healthcare 2030. The department very much refers on page 240 on our 5-year strategic plan. If you read the 5-year strategic plan, the department is committed to 2030. We have not replaced anything in the 5-year strategic plan that says it replaces 2030. What we're busy with now is a strategy of recovery, which still is within the parameters of 2030, the principles of 2030. And we will still be operating within that parameters. But the key question that Ms. Kivich is asking, so what does it mean for community engagement and community partnerships? So our commitment is to build a social compact. She's rightfully saying COVID really interrupted this. But our understanding was we wanted to use 2030 was silent, or 2030 as a statement, that as universal health coverage becomes clearer, it still needs to be incorporated. So our understanding is we got a 5-year strategic plan that very much speaks to 2030, but puts universal health coverage very central onto it. And the commitment from the department is to build a social compact with all partners on how to implement universal health coverage in this province. And the minister has made it very clear that universal health coverage becomes the big thing that we need to get right. But the vehicle we'll use for universal health coverage is very much the principles of Healthcare 2030. So I just want to clarify in terms of that. And Ms. Isaacs, I think I've engaged the issue of Klipfontein, the regional hospital, and the engagements. The community health workers, there is a discussion at community health workers at the National Health Council meeting. So the minister and myself is part of that structure. What has happened in the country is that Gauteng has implemented a system unilaterally of employing community health workers as public servants. There is no legal framework to allow community health workers to be public servants. And what has happened in Gauteng, it is an unaffordable process, and there's lots of unhappiness with what's happened in Gauteng. They're the only province that's employed people as public servants. What has happened is the other 8 provinces are processing payment for community health workers, the other 7 provinces, via Provincial, which in itself is just a processing of paying people through Provincial. They're not employed by government, but they're getting paid through Provincial, which is in itself also difficult to manage. We're the only province that maintain that we have a clear relationship with community health workers being employed via non-profit organizations. There is a process that is currently unfolding, and there's a recommendation of how to formalize, irrespective of who employs community health workers, is to formalize what the basic conditions of employment should be for community health workers. Whether they're employed by the state or by NPOs, there needs to be something that regulates exactly what their hours are, what their uniform are, what their payment, their conditions is, and the benefits that community health workers. That's the process that's currently underway at the national level. Again, Minister Mbombo is very clear whenever we are approached. We are party to that process, and there's a formal engagement with the bargaining chamber to take this process forward, and then with the Department of Labor. But we are just part of that national process to formalize all of those issues. In terms of the emergency services and triage, I would encourage Ms. Isaacs, when she has specific instances where somebody has been incorrectly triaged, to bring that to the attention of ourselves, because the triage system is very clear. You go into a triage nurse, she takes your blood pressure, she does that, she does that. So a triage nurse doesn't just decide on a whim that somebody is green or yellow or orange or red. It's clear criteria. And obviously when somebody is significantly ill, now everybody that comes in say, I feel ill, or that system is designed for somebody to examine them and decide who is more compromised than others. If you have any instances, please report specific instances if you feel that that has not been accurately done. The merger with the city and the province, let me just clarify. There's conversations currently between ourselves and the city about 9 facilities where the province and the city is sharing the same building. The undertaking from our side is, and this will apply to Heideveld, as it will apply to all other 8 facilities, whenever the city staff that's in that facility that currently renders services withdraws so that the province can render that service, additional staff will be handed to each facility to be picking up that specific role. And then from a Gugulethu perspective, the priority for Klipfontein in terms of new facilities or replacement facilities has always been 2. The one is the Gugulethu CHC to be built in a new site, and the other one is the Hanover Park CHC to be built in a new site. Those 2 still remains the infrastructure priorities for Klipfontein. And as far as I'm concerned, that is the process being followed by the staff in that area to make sure that they secure the land, secure the place and the budget to start those processes. Thank you very much, Chairperson.
Thank you very much, Jody, and thank you so much, Minister Mbombo, to you as well. Are there any other pressing questions or perhaps a follow-up question that you might have? I see Ms. Kivitz and I see Ms. Isaacs, as well as Ms. Malebo.
The 10 health facilities, page 239, the 10 health facilities from the city that's going over to province, is that the amalgamation of services, or is it just a takeover? And once again, the department is saying to this committee that the engagement is with the elected members of health committees. Not even the elected members at those facilities are aware of the closing down of facilities in our different communities. So I'm not aware if this portfolio committee is aware of the facilities that are going to shut down in communities. In the report, it says that the 10 primary healthcare facilities on page 239 are going over to the department. So the community needs to understand what is happening. And Madam Chair, I think for us in communities, if we don't know who renders the service, we don't know where to complain. So if it is a city facility, I mean, I'm going to use a very good example, St. Vincent. St. Vincent was a dual facility. An incident happened, the provincial staff then went to Symphony Way. The city took over the services at St. Vincent. The community is under the impression that the services rendered at St. Vincent is provincial, and yet it is not. And we have that in facilities where we have dual services rendered by two different entities, the city and province. So I think the department needs to tell us very clearly of what is really going to happen here. I mean, the late Ivan Thoms and Uncle Polly, amalgamation is a very long process. We've been talking about it for years. We want that to be made very clear. Then 238, the mental health services from the HIV/AIDS budget to the NHI budget. Now, if the NHI budget is not in full operation yet mental health in our communities are at breaking point. Are our community health workers fully capacitated to ensure mental health services runs efficiently and effectively with the resources allocated to render the service? Then on the page 220, the
Ms. Kivitz, can I please ask you to conclude with that?
I'm going to
question,
conclude
please?
with that question, and that is on the agency personnel. Is it cheaper to appoint agency personnel than to appoint a person permanently? Thank you.
Thank you very much. Mrs. Isaacs?
Tamara is just spoke about the mental health issue, which is a very great concern to us in our communities. The fact that we have very few, I don't want to use the drug centers, but there is very few centers that takes up the addiction, the people with addictions. So we have one facility in Manenberg where it's the Matrix program, which is run through the city of Cape Town. It is being promoted through the community for people to make use of that facility. But we need to look at seriously how we can what's the word now? How we can assist those with mental issues. And the mental issues that we have now since COVID started is more stress related, where adults, not really children or youngsters or youth, is being taken up into the facilities with the mental disorder, but it's adults, parents that is ending up at the facilities for stress related issues, and that is a serious thing for us as a community, because as mothers we need to find a way how we can look after our families, but nobody else looks after us, and at the end of the day we end up in a mental facility, or we sit with a mental condition at the end of the day. So that is the one thing. The other thing is that I've been listening to looking at the tender of the regional hospital that is going out now. So, and that is a concern as MERP, because MERP hasn't been involved in any update from the Department of Public Works, and we are still working within the area. So there's no communication between the Department of Public Works and MERP. So, and we have major problems where the community, when that building is going to start, we're going to have major problems because there is a business forum within the Menenberg area. So how are we need to look at those things. I know it's a very difficult question here now because it's not health related, but it's got to do with the fact that the hospital is going to be built and who's going to benefit at the end of the day of that work that is going to be done there. So as a community person that is also wearing another hat, we need to look at how the engagement through public works and the community structures is working, because there is no communication between, because now if I go back and report and say that the tender is going out in May, nobody knows about it. They will only see it in the newspapers, or tenders is going out to certain companies. So that is the kind of communication between public works and Menenberg that is not happening. Just want to bring it to attention to this committee.
Thank you very much, Mrs. Isaacs. Mrs. Malebo, you will be the last speaker.
Thank you, Lady Chair. Yeah, what I want to know is that the people in the rural areas, the health committees, some of them, they don't know what is going on. They are health committees, but they never get trainings, and they don't know what is going on. They never even hear about the NHI. So I just want clarity on when are those people going to get training. Thank you very much.
Thank you very much. Ms. Malebo, HOD. Would you?
Thanks. Just to start with the last one for the NHI and the statutory bodies. Not only PESAP structures in the rural areas, but we even held a big gathering before the COVID. It was in Gauteng, related to the NHI. So it might be the new people that come later, or if that will be not. I'm talking specifically about the NHI. That one has been done. And also, as I indicated earlier, because of the COVID, where people who have to limit the traffic that goes to the health facilities, some people ended up not necessarily participating around that. And then the last one, before I give it to HOD, there are no facilities that are closing, and there's nowhere, anywhere in this document that talks about the closure of the facilities. Nowhere. No one mentioned any closure of the facilities. We are saying that instead, which is what it has always been, that kind of a conversation, that where we are sharing under one roof, the discussions was that one sphere must take it over, which is, it went up to the city council in 2021 or something like that, where they agreed that these 9 facilities must go to the province because they have to prioritize municipality-related services, because it's an unfunded mandate for them. So there are no services that are closing. In regard, in terms of party being formed, the relevant, at the time when there was this last year from the city, at the time, the relevant statutory bodies were informed in regard to that. This is now, there's going to be some ownership, but it's still going to come to the province as well, but there won't be any changes. Just to make an example where it was not the first time, Chair. If you look at the retreat dental, was it the oral, which used to be a part of the city, and then it went to the retreat us. If you think of the child health that used to be city, Amanda Michael Mapongwana, it just automatically came to us. If you look in terms of the Bothasech, I'm just making some of these examples that it's not that it's a new thing, because in most instances, the anti-SARAs, when they go into the facilities, they don't know who is there, because they only know there are clinicians that are there. They don't know about that part of it. So there's no changes in regard to that part. However, having said that, indeed, in regard to, because we mustn't take, we mustn't dismiss that the issue of having, whether it's a FYI, that kind of engagement, which is already has been part of the plan, until why now that they have to put on pause or that. I know that Akona is busy setting up for towards the end of, I think, April to May about this engagement, not only for these ones, but generally in terms of where we are, what we mean by the recovery, health recovery, and all of those. It was about, there is a technical team that is working behind, because experiences when we were doing the provincialization of the rural health services, I think it was a 3-year process until 2007 or so. The lessons learned from there, where we just absorb buildings and all of those and take it over. It did have some of the other challenges. So that's why it's crucial that the finance team from the both of sides, they must understand what does it mean. The infrastructure team needs to understand what does it mean. Like recently, I visited Ravensmead in terms of looking at how things are. But the staff that are working in all of these, they already know. They have been briefed. Everyone is fine about it. So, Chair, NBNB, there is no closure of any facility. That is the word that needs to message that needs to come out of this. There is no closure of a facility. Thank you.
Thank you, Minister. So yeah, I think Ms. Kivitz was referring to numbers of pages and statements about facilities closing that doesn't exist in this document. I think that's the point the Minister is making. There are processes, and Member Windvogel also contacted me about that, which is city processes, where there is 9 facilities where we are in the same building. Our commitment is that we will assume responsibility for the services currently rendered by city staff in the places where our provincial staff and city staff shares the same building. Our commitment is no services are not being rendered. And as the Minister said, that's the 9 places that's left. And Ms. Kivitz quotes Dr. Ivan Toms. When Dr. Ivan Toms and I worked together on this issue, there were 22 facilities where we were sharing the same building. This is the last 9 of the 22. Now you have to ask yourself what has happened with the other 22 minus 9, because that is the case. This is the Macassars, it's the Michael M's, it's all the places. None of those places did the services stop. Wherever the province assumed responsibility, the province actually took over the service that was previously run by the city in those places, and very soon after that expanded the package of service in each of those places, including Kleinvlei and all the places. So to be very clear that when we talk about that in the province's role in this, that's our role. The city has raised an issue that there's 9 facilities in close proximity to provincial facilities. And they raised the issue that in terms of the city, they want a consolidation. That's got nothing to do with us and the province and the city working on that issue. That's an issue that the city has raised, and the Minister has made it very clear, we've made it clear, we're not party to any decisions in relation to those other 9 facilities that's in close proximity to provincial facilities. So we just want to make that absolutely clear, Chairperson, in terms of the process. When it comes to mental health, and I'm glad Ms. Kivitz asked the question of mental health, and I'm glad Ms. Isaacs asked the question of mental health. Mental health has been recorded as a provincial priority out of COVID. So Ms. Isaacs, I can give you the assurance, and I can give Ms. Kivitz the assurance that I've been asked as the head of health to co-chair a steering committee to address mental health as a whole of society challenge for the province. So I do it with the head of education, the head of DSD, and the head of culture and sport. And we've had our second steering committee meeting yesterday. And our commitment is to map in each geographic area what is our existing non-profit organization capacity, what is our existing services, and how do we address the mental health challenges in a comprehensive way. So I can give you the assurance that that process is underway, and when appropriate, that will be shared in the appropriate geographic areas which we're doing. It's like the safety plan. It becomes a mental health plan, recovery plan for the province. I can assure you it's everybody working together with municipalities and all NPOs to do this as a coherent strategy. In terms of agency staff, Muskiewicz's question of is it cheaper to employ agency staff? There is a stated commitment in our department that we want to move towards full-time employment as a preference. And we have moved to, as much as possible, create the space for our staffing to be less and less dependent on agency arrangements. So there's a very clear undertaking from our side to move away from that specific towards more permanent staffing. And then the MERP and DPTW engagement with Ms. Isaacs. I can understand the frustration, Ms. Isaacs. I know the colleagues involved with this. And I can understand that there needs to be a clearer link with community structures around it. We will most certainly take that message to our Transport and Public Works colleagues. We'll take it to our city colleagues. And for Klipfontein and for Bellhou and for every other place where we're going to be, it would be in our best interest that there is structures that can engage communities in a constructive manner. So we will undertake to actually convey that message. But as you rightfully say, it's not primarily us that needs to actually put those systems in place. And then I think the last question Minister's answered. The issue is the rural committees and the metro committees. When the appointment of committees are done, there is a standard training program. This training program is done in a decentralized way. It's a combination of an outsourced person and local in each of these areas. If she's aware of any specific committee that's not received any training, she must just make us aware. Because according to us, every health facility board that is appointed is supposed to get through standard training and orientation. Thank you very much.
Thank you, HOD. Mr. Kay, something from you?
So, Ms. Isaacs, can I just clarify something for you? Because I don't want you to come out of here with a misconception when we talk about awarding of a tender around Klipfontein. So if I may just clarify that. So what is being done at the moment is for the professional service providers, i.e. the architects and the engineers who are going to design the building so that when we go to engage with the community, we can say, look, this is what it's going to look like. This is where it's going to be. This is how it's going to be placed. This is going to be the access that we've got. But without that engagement, we've got nothing to come to you with in paper. Now, that's obviously quite a complex and complicated thing, which requires architects and engineers. This is not about bricks and mortar around building the hospital. Now, as much as Manenberg has got a very active community business forum, Khayelitsha has also got a very active business forum. And when we built Khayelitsha Hospital, we engaged with that to make sure that the local community was uplifted. Exactly the same principles will apply as we move by and around the province. So I just wanted to make absolutely clear that you're not going to see bulldozers, and you're not going to see the primary schools being knocked down. That's not what we're talking about. At the moment, we're talking about design and the pictures that are going to go with it and the plans that go with it. Thank you very much, Chair. Thank you.
Absolutely wonderful.
I just want to say thank you very much for that explanation. Because if you look at, you say tender, then your brain would say to you, yeah, we're going to build, and nobody's been informed. So thank you for that. We have met in 2018 with the engineering team explaining the situation of the school. But thank you so much for explaining that.
Thank you very much, Mrs. Isaacs. And you must now be even more glad that you are here today to get that peace of mind. So thank you so much. On that note, Minister Mbombo, thank you so much for your time and for your effort and for always coming to the standing committee, the HOD and all departmental officials. Thank you for affording us this opportunity to deliberate on vote 6 this morning and interrogate and dissect. And I'm sure after this, there will still be more questions, but we'll direct them to the minister as well as to the department. So thank you so much for your indulgence to this committee this morning. Any closing remarks from your side?
To thank the team for preparing all the documents, and it's not all about we only meet when you are here. So I have to be schooled first in terms of the each item budget line and all the monies and all of those. So thank you, team, for doing that, and also thank you from the representative from the community for making us to account, and also chair and your standing committee. Thank you very much for your inputs. Thanks.
So much, Minister. Dr. Klute, any closing remarks from you?
It's a bit dangerous to speak after the minister. But I'd just like to say thank you to yourself, Chairperson, and the committee members. I said it previously when we did the annual report. It's really a privilege to engage with all of you. It's obvious that you take your oversight role very seriously, and we respectfully submit ourselves to the oversight. And it's a pleasure for us in the manner that we can engage you around these issues very constructively. And then to, I would say, my colleagues and friends from the community structures, it's good to see them all. And I can guarantee to each one of them, the minister and us as officials are extremely committed to building a social compact with the people from our community structures. That is our commitment. We want to work and walk a path together, and we will walk a path together with each one of you. So thank you for your inputs. We take that also very seriously. Thank you.
Thank you very much, Dr. Klute. And just from our side, thank you very much to our members of the community for being here this morning. Not be the last for 2022. We welcome you back to this house, and wherever we go as an oversight body, also to meet up with you within the respective communities. So thank you very much for being here this morning. And please be safe. And Minister, department, and yourself are welcome to help yourself to lunch. Thank you very much. Can members please just stay behind for a brief moment? We just need to deal with our committee business. I'm tired. Mm. Yes, yes. Thank you so much. Keep well. Thank you very much, Namawetu. I forgot about them, eh? Namawetu and member Van Vogel, you'll have tea at the back. She was like, whoopsie. Oh my. Are you okay? I see your hand, member Alan. Any resolutions?
Thank you, Chairperson. I wanted to move that we deal with the adoption of this particular matter that we discussed today. Am I before the time, or will that be raised later?
We thank you very much, member Allen. We're just going to deal with resolutions. If there are any, I will immediately give. Don't accept any minority views today. Are there any resolutions from members?
Yes, Chairperson, from my side.
I recognize you, member Baku Baku Force.
Thank you, Chairperson. Mine, I would like the department to provide us with detailed explanation regarding the integration of clinic service in the city and the full details of clinics that may be closed down as a result of this and reason thereof. The department must provide detail of the number of the staff members that may lose jobs as a result of clinic closure in the city.
We've got that noted. Thank you, Member Bakufos. Anything from Member Kego? Nothing. Member Van Vogel? Nothing. Member Plato? Nothing. Are you covered? Thank you. Thank you, Member Van Vogel. Have we haven't requested the district health plans previously? No. Can we also please just request that? Yeah. For the entire province. Okay, that deals with our resolutions. Members, we are now at the point where we need to indicate whether we support or do not support the committee report. So we report on the Standing Committee on Health on vote 6 in the schedule to the Western Cape Appropriation Bill B2 of 2022, dated today, the 15th of March 2022, as follows. The Standing Committee on Health, it is on the screen as well. The Standing Committee on Health, having deliberated on the subject of vote 6, health in the schedule to the Western Cape Appropriation Bill B2 of 2022, refer to it in accordance with Standing Rule 188, reports that the committee either supports or do not support the vote that is referred to, and which we have dealt with today. I now ask the committee whether they support or do not support the vote. I see your hand, Member Allen.
Chairperson, based on the extensive deliberations and the work of this committee, I hereby move that we support this vote for the Department of Health. Thank you.
Thank you very much, Member Allen. Can I have a seconder? Thank you very much, Member Plato. I see you, Member Van Vogel.
Chairperson, we will make use of our minority vote, Rule 90, as the ANC, African National Congress.
Thank you very much. I see Member Baku Vos. It seems like it's an old hand.
Let me lower my hand, Chairperson. I think it's an old hand.
Thank you very much, Member Baku Vos. Member Keho, do you wish to express your support or non-support for the report?
Oh, yes, we express our non-support, but the minority as it may be.
Thank you very much. I must just have left you out because your hand wasn't raised. Just joking, member. Thank you very much. So the report of the Standing Committee on Health on vote 6, health in the schedule to the Western Cape Appropriation Bill B2 of 2022, dated today, the 15th of March 2022, as follows: that the Standing Committee on Health, having deliberated on the subject of sex health in the schedule to the Western Cape Appropriation Bill B2 of 2022, refer to it in accordance with Standing Rule 188, reports that the committee supports the vote that was referred to it, and in terms of Standing Rule 90, the African National Congress as well as the Economic Freedom Fighters expressed its minority view to not support the vote. The committee report supports the vote with the minority view of the ANC and the EFF recorded as such. Are we all in agreement, members?
Yes, we're in agreement, Chair.
Thank you.
Thank you.
Thank you very much, members. That deals with our business of the day. Thank you so much for your valuable input and for your deliberation on this specific vote. It is really duly appreciated, members. That concludes our meeting today. Minutes of the meeting will be adopted at the next meeting. Sure. Thank you very much, members. The meeting is now adjourned, and you are also most welcome to have lunch in the members' lounge. Thank you so much.
Bye to everyone.